Depan lagi boleh tak? Orang boleh. Depan lagi okey. Buat sini ya.
Kotor ni.
Mungkin ni boleh dengan silat seperti you kan. Boleh. Ada tisu je lah.
Ini kita nak tunjukkan presenter lah kan? Ke audience?
Slide dah memang akan
Slide ada. Maksudnya nanti kat YouTube tu di sini lah. Kita nak bagi orang tengok audience ke tengok presenter? Presenter kan? Presenter kalau duduk tengah akan adjust lah ni. Tak pun je. Ni sampai sini.
Oh, dia dengan
YouTube.
oh.
Boleh masuk kursi lagi ya?
Boleh tapi tak mahu dapat kursi ni.
Tak ada kursi lagi.
Tak tahu mana dapat kursi lagi.
Berjaya. Yeah, somehow it helps when you're not around. Just to show that it works.
Presenter kena pakai komputer ni lah kan?
Presenter
First one Paralympian. Okay. Like it's also first one see Paralympics saja. Okay. Okay. So there are differences tak? Budak dengan dewasa beza tak? Beza sangat ke? Beza sikit. Tak ada. Dia lah. Ini besar. Standard size, cervical taller, standard size, spinal cord, standard size. Ring kan? Betul tak? Kecuali yang untuk ni besar sikit lah. Tapi untuk budak, kecil saya besar, ini sampai ni sikit. So dia difference. It's not working. Oh. Okay. So, okay. You have to control for me. Okay. So daripada atas MBA common tak? Common? Okay. NAI biasa nampak tak? So patient yang R2 hari tu you all suspect apa? NAI. Okay. So cerita yang R2 nanti saya cerita lah apa yang sebenarnya tak tahu lah. Okay. Yang semua yang tak tahu tu nanti saya discover. Okay. Okay. So I talk to you. Orang jalan kaki kena langgar kereta. Biasa apa injury? If you are this tall and the car hits you, you hit you kat mana? Kaki ke abdomen? Tengok kereta lah. Kalau SUV langgar, kena mana? Chest atau abdomen lah. Okay. Kalau tengok SUV tinggi ke rendah lah. Kalau kereta, mungkin kena kaki di sini. Kalau orang dewasa biasa kena kat sini. So the pattern of injury is different. Okay. Kalau jatuh bangunan, orang dewasa, you tahu, dia tengok dia jatuh macam mana lah. Usually they try to this one, either the body or the back or the structures. But children usually jatuh head first because heavy, dia akan jatuh dulu. Okay, kalau jatuh bangunan, you dah tahu, okay, this one is dangerous for a child. Kalau untuk dia jatuh double decker, bahaya tak untuk kanak-kanak? Tengok ketinggian budak. Okay, kalau budak tu budak darjah 6, tinggi dia lebih kurang macam ni kan? Double decker dia tinggi macam ni kan? Bahaya tak? Not so dangerous lah. Kalau budak 1 tahun, tinggi dia macam ni. Double decker tinggi macam ni. Bahaya tak? Bahaya sebab dia ketinggian dia lebih daripada 3 kali. Okay? Okay. Next one. Okay, so now we talk about differences for anatomy. Adult anatomy, more or less not much difference. Except maybe orang dewasa yang dah tua sangat, gigi dah patah, atau tak ada gigi, atau pregnant, that one memang different lah. Children, head is big, mouth is small, tongue is big, ada gigi, tak ada gigi, ada kan? Apa lagi? Dalam tu bentuk dia landscape. Orang dewasa punya straight, budak punya dia bengkok sikit. So that's why kalau you tengok tube dalam HKL untuk kanak-kanak, ada yang dekat, ada yang tak dekat kan? Faham tak apa dekat, yang tak dekat? Ada some angguk, so they don't know. Okay, nanti kita check immunity size 4, tengok dia ada dekat atau tak dekat. Ada yang ada kaf, tapi ada yang tak ada kaf. Tak ada kaf. Nanti saya bagi sikit. Sebab sekarang kita sudah suka boleh kaf, tapi kalau tak ada kaf, tak salah. Boleh guna yang angkaf. Okey. Untuk biasa saya tak pernah tak biasa cek jersey trolley untuk kanak-kanak. Kita tengok kaf untuk kanak-kanak yang saiz kecil memang dia angkaf because of the added differences. Okey, nanti buat jalan doktor kenapa jadi pelik je? Jadi boleh guna tak? Okey. Kita check back. Okey. Okay, spine, how is the spine different? Kalau most of you, not most of you lah, all of you, your bones already keras already, right? Dah cukup size already, right? Dan lepas ni, lepas guna handphone, dia akan jadi degenerative macam ni kan? Okay. Tapi untuk budak, apa beza? Dia masih nak membesarkan. Tulang dia belum penuh lagi kan? So, dia banyak leverage, dia banyak flexibility. So, bila kepala dia besar, dia terhantuk. Kalau macam you, have you seen the patung bobblehead? Yang tong tu. Okay, ingat tak? Patung tu. Macam ni, angkut-angkut tu. So, baby punya head like that. So, if you hit, dia akan injury. Tapi injury dia bukan lower. Injury dia adalah higher cervical. So, that's why for children, if let's say the mechanism is very bad, please put on the patient on a cervical protection. Okay, cervical protection in the sense, nanti cerita. Ada kita guna collar tak untuk semua budak-budak? Okay. Chest wall. Chest wall tu macam kaki budak yang jalan kena langgar dengan SUV. You kata mungkin ada chest injury kan? Tulang dia keras ke lembut? Lembut. So biasa dia tak akan crack. Jadi fracture doesn't break. dia akan lentur ke dalam dan dia akan press against the lung. So dia akan dapat banyak lung confusion. So kadang-kadang bila buat X-ray nampak kan macam putih-putih kan, sebenarnya dia sebab impact. Tapi bila tengok tulang rusuk tu cantik tu, dia tak patah. Sebab dia bend and then come back. Sebab dia macam rubber band, dia macam masih buluh yang muda tu. Okay, so far are we okay? Too fast, too slow, or just okay? Okay, good. Oh, we are here already. Okay, so what about breathing? Because their lung is smaller, they need to breathe faster to move more oxygen. Your lung is big. You move 12 times a minute, 20 times a minute, you can have enough oxygen. Tapi baby punya lung is much smaller, right? Tengok BPM dia pun kecil je kan? So you kena back faster lah because nak bagi dia lebih banyak oxygen. Kalau you back ikut masa yang masa memang tak cukup. Okay, so what is the normal rate? I'll show you the graph in a while. Okay, so because now the airway problem and the breathing problem is very common, it is very easy for children to die from trauma, not because of circulation, because of airway and breathing problem. Okay, so jangan cepat-cepat tak sangat. Okay, I want to settle breathing, tapi settle bleeding dulu. Tapi bleeding tak okay. Jadi all these people squeeze at the back, it's fun or not? Nice chat. I don't need people one. I already have breakfast already. Sorry, I was lah. Pakai lah di depan lah. Belakang tu jadi macam no social distancing already. Okay. Statement nombor 1 tu 70 hingga 80 mil 1 kilo. Okey. Dalam badan you, kalau orang dewasa 70 kilo, standard kandungan darah dalam badan you adalah 5 liter. Because about 490 ml kan. Okey, kalau untuk budak, kalau budak tu 10 kilo, berapa banyak isi padu darah dalam badan dia? 700. Okey. Ini botol 250 ah. So 1, 2, 3. 3 botol saja untuk bayi 7 bulan. 7 kilo yang agak-agaknya biasa budak 6 bulan lah. Okay, so 7 botol. Kalau satu botol ni, okay, mak dia kata, tadi ada luka kat kepala dia. Saya letak kain bag. Dia tunjuk kain tu. Kain tu besar gamsi, fully soaked. That is different to this banyak. Kalau orang dewasa mungkin boleh tutup mata lagi lah. Okay, tak apa, kita bagi nombor saya. Tapi untuk budak tu, that is already 1/3 daripada isi padu dalam badan tu. So always think about your patient's age, your patient's weight, and how much blood they have. Okay, not everything is the same. Okay. So because the heart is healthy, dia akan pump. Pump lah. Enjin baru mah, enjin BMW mah pump. Tengok sudah tak ada minyak, rosak terus. Okay, so you jangan tambah balik minyak. Okay, and stop the bleeding. Can I? Okay. Okay, so this one, if you look at this one, the pointer doesn't work. Okay. Okay, so this one, the line is very small. Nampak saya punya bintik kecil tu. Can you see that? Tak nampak? Very small bintik ah. Okay lah. Dia kayu ah, tak ada kayu. Okay. 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 So biasanya you all tahu itu Brosco tape tak? Mana mau cari itu Brosco tape? Pick rock. Okay. Kenapa penting itu Brosco tape ah? Pasal budak datang, you tak boleh ambil patient bleeding tu pergi letak atas penimbang kan, nanti bleeding atas penimbang. So you kena agak-agak guna Brosco tape tu, dia ada pita, dia panjang, letak kat patient tu, dia akan beritahu you. Pesakit ini antara usia 1 tahun ke 2 tahun. Berat dia adalah antara 10 hingga 14 kilo. Saya boleh sekarang kira berapa heart rate dia, agak-agak berapa blood pressure dia yang normal, berapa RR dia yang normal, dan kalau saya masukkan IO, masukkan CBD, saya boleh tahu dia punya IO dia banyak mana. Okay. So kalau you ada photographic memory, you boleh hafal ni masuk otak. Kalau boleh keluarkan you punya iPhone 13, ambil gambar. Kalau Ada iPhone, Android, Samsung Galaxy. Okay, cannot remember, go and take out your proslo tape. Okay, I don't memorize this because it's difficult this time. Apa 25 benda nak hafal kan, saya tak ingat semua. Okay, tapi saya boleh agak. Kalau anything above 160 is tachycardic. Kalau untuk dewasa mungkin above 120 kata tachy kan, 100 pun kata tachy, tapi untuk pediatric anything above 160 is tachy. Okay, anything blood pressure less than 90, you start to get worried already. Okay, can okay not? Okay, so because you know what is normal, you boleh tahu, okay, patient ni sekarang heart rate, katakan budak 1 tahun, heart rate dia sekarang 100. BP dia 120/80. Blood pressure dia is high and heart rate dia is low. This is actually Cushing's for this patient. Cushing reflex, you all dah belajar kan, head injury kan? Okay, for adult that is normal, right? 120/80 with 100, right? So you have to remember what is the normal for that patient. Cannot remember, take out the proslo. Make sure that this picture is your screensaver on your handphone. Okay, this one is over. So why so? Okay, so this one the same thing, head and neck, and then the skin. The skin that cover the patient is a lot more for child. Bukan peratur, dia actually apa benda saya nak kata. Okay, kalau budak tu kecil, ingat tak isi padu sfera yang you belajar masa matematik tingkatan 4? Isi padu sfera kecil dengan isi padu sfera besar. Okay, dengan dia punya surface, dia punya kulit dia. Kulit dia. Okay, so kulit untuk benda yang kecil, dia punya surface lagi banyak. So sama macam bayi, walaupun dia nampak kecil tapi kulit dia lagi banyak. So kalau katakan untuk burn, dia akan banyak lagi surface exposed, dia akan cepat sejuk. Okay. 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 So this is why. So that's why kalau you biarkan pesakit tu lama-lama di tempat yang sejuk, aircon yang kuat, bilik tu sejuk, you rasa selesa. Tapi untuk budak tu dia akan jadi hypothermia. So lepas dah examine head to toe, back to front, tolong cover balik. Kalau tak ada blanket atau patient terlampau sejuk, make sure you all letak warmer blanket. Apa yang triad of death tu yang you belajar semalam masa circulation punya lecture? Ada 3 benda yang can cause patient to bleed a lot. Acidosis, hypothermia and hypovolemia. So hypothermia, don't forget, is very important in children. Okay. So pediatric trauma team. You all heard about adult trauma team kan? So same concept for pediatric trauma team. Tapi in HTA kita tak develop lagi. Di setengah tempat, pediatric trauma bukan led by pediatric surgeon, dia actually led by adult trauma surgeon. Sebab pediatric trauma tak banyak, so adult surgeon akan tahu semua. Dia jaga sekali dengan budak. Kecuali yang budak kecil sikit, yang kecil sangat tu memang lebih difficult. Tapi biasa adult surgeon will take over. Okay. Okay, so when we talk about cardiac arrest, respiratory failure, tadi ada cakap lah, airway dengan breathing big issue kan in children kan. Circulation is important, but airway and breathing, don't forget, is also actually quite high up. Okay. Now this one is about your cervical immobilization. Biasa you letak spinal cord kan untuk sakit dewasa kan. Biasa tak? Okay, tapi untuk kanak-kanak, don't forget lah. Bila you letak spinal cord biasa saja kan macam ni kan, kepala dia akan dongok. Is this flex or neutral position? Flex or neutral? Flex. Is that okay for cervical spine? What you want? What position for cervical spine? You nak position apa? Neutral kan? Neutral ke flex? Neutral. So don't forget, kalau you rasa kepala dia besar sangat, you kena letak mungkin satu layer blanket atau bedsheet di bawah supaya dia punya spine tu neutral. So biasa bila you first look tu, bila you airway, pasal you nak manage your airway dengan cervical spine kan, you tengok. Kalau you rasa you kena betulkan kepala dia jadi macam ni, memang you kena buat padding kat dia punya spinal cord. Okay? Kena? Okay. Jaw thrust. Jaw thrust dah belajar dah? Belajar kan? Jaw thrust. Okay, tak payah cakap. Oksigen kena bagi? Yes. Okay. Intubation, you all okay kan? So for children, we intubate, depend lah kalau patient ada potential airway problem, potential breathing problem, potential circulatory, like for example, what's that thing called? You need to maintain oxygenation, like for patient yang ada head injury, then you need to intubate. So same indication. Okay, so far? So What is cricothyroidotomida? Ibrahim dah ajar kan? Right. Okay. So surgical cric untuk budak yang besar lebih dari 8 tahun sebab dia punya membrane tu senang nak rasa. Tapi untuk budak yang kecil, dia punya membrane tu sangat kecil. Kalau you nak potong plate, you akan terus potong dia punya dia potong depan dia punya cricoid cartilage. So usually for younger children, we guna needle. This is a needle. Okay. So needle for pediatric patient less than 8 years. Okay. Siapa yang ada datang yang hari tu airway punya procedure dah belajar dah. Okay. Okay. So yang untuk cervical collar. Okay. Cervical collar, you ada size kecil tak? Yang paling kecil sekali tu. Orang yang pergi pre-hospital care. Tak ada fix kan? Kadang-kadang terbawa, kadang-kadang tak terbawa, kadang-kadang ada ambulance. Mostly dibawa. Okay. The problem with some of the children is like this. Kepala dia bosok. Lepas tu leher dia gemuk. Lepas tu dia macam ni. So you nak lepas tu kepala dia macam ni. So kadang-kadang kita recommend kalau tak ada size jangan paksa. Bila you paksa dia akan jadi macam ni. So that is extended which okay. So kadang-kadang tak ada size atau budak tu meronta sangat atau dia memang you memang cannot find lah. You push also cannot. Okay. So kadang-kadang apa yang kita buat sandbag, kita letak tepi ni atau you ada lateral neck immobilizer yang ada macam tu yang tu you can use that one and then you just take under the chin and over the point. Good enough. As long as the head doesn't do this, you're okay. Yeah? Okay. Kalau ada size then okay, but make sure jangan sampai kepala tu jadi macam tu. The worry is that most of the time because tak ada size, dia paksa. Sebab yesterday we received one patient, they try to put the collar. Bravo, bagus. Bukan HKL lah, bukan lah, private punya. Okay. First dulu lah. Okay. Tapi masalahnya sebab budak tu antara sizes, so when came that time the head is extended. Tapi syukur dia tak ada injury lah, so we are lucky that sense. But when came in was like, oh, okay. Put on the bed, quickly assess, take off the collar because the head was like that. Okay. Kalau budak tu kata sakit lah, buka cepat. Okay, so feeding you punya bag, you kena tahu apa. Kalau katakan you kena bagi ventilation, contohnya patient punya ventilation tak bagus, contohnya dia bernafas tu. Is that a good breathing or not good breathing? Itu macam pernafasannya tak bagus kan sebab dia macam sangat slow, sangat labor, macam dia tarik nafas panjang baru nak lepaskan kan. So that means oksigen cukup ke tak cukup? Cukup. So yang ni patient ni kena bagi oksigen kan. Kalau bagi oksigen dan pernafasan dia okey, and good. Tapi kalau pernafasan dia jadi lagi lemah, kena support. Okay. So kita support, kita biasa start dengan back valve mask. Back valve mask, please use the correct size. Ada banyak size kan? Okay. Some people say, okay lah, tak apalah. Size besar pun bagi oksigen jugalah. Saya bagi guna yang size adult tu sambung kat budak lah. Masalahnya, bila you excited, you akan pump macam mana? You tekan macam ni ke? You tekan macam ni? Tekan macam ni kan? So bila tekan macam ni, kalau you bagi udara tanpa banyak, pressure tinggi, you akan cause barotrauma, mungkin jadi pneumothorax. Mungkin tadi tu kecil punya pneumothorax, besar sekali. Oh, besar punya pneumothorax. Okay? So must use the correct size, enough pressure. You nampak chest rise, cukup dah. Jangan sampai, wah, sampai berhenti. Okay? So, use the pediatric size. Dia ada unit yang ni paling kecil ni. Dia punya besar dia mungkin besar sikit daripada ini. This unit one. Then the slightly bigger one and then the big one. Big one kalau tangan kecil tu memang satu tangan tak sampai lah kan. Okay? So use the proper size for the pediatric patient. Okay? And then, budak kalau dia trauma dia suka menangis tak? Bila dia menangis dia menjerit tak? Jerit. Lepas tu bila dia menjerit dia akan tarik nafas. Lepas tu udara tu masuk paru-paru dan masuk perut. So apa akan jadi? Perut dia akan penuh dengan udara, campur dengan nasi yang tak hadam, dengan susu yang tak hadam, nanti dia akan lepas tu wah, bau susu basi di dalam gigi. Okay? So make sure you jangan pack tanpa baik sebab dia akan vomit. Okay? Bila dia vomit dia keluar tak apa, masuk paru-paru problem. Okay? Next one. Okay, so chest tube, chest injury, you kena masukkan chest tube. Needle thoracocentesis untuk adult buat kat mana? Ya kan? Okay, because some adults are big. Most of the pediatric patients are small. So you can still use...
So boget.
That's it lah. Kalau anyone want to take over lecture can, I don't mind, I can sit down. Okay, it's okay. So kalau we are not here, we are actually next one. Go back. Oh, this is. Yeah, that's right. Okay. Okay, so for pediatric you can still use here. For chest tube sama lah tempat ni lah. Okay. Kan ah? Okay. Sorry, Dr. Azhar. This is very dangerous. Sorry, I postpone, so I think you know my skin. Okay, okay. Okay, so your Broslo tu yang cat ni kan? Is that the same one that you all have? You also use that one. And then kalau katakan tak tahu berat, tanya parents sebab sana dia timbang kan, especially budak kecil dia selalu timbang kan. Dia guna berat yang paling dekat tu atau guna Broslo. Kalau katakan budak tu dah 7 tahun biasa dah timbang sangat, guna Broslo lah. Okay, bila you guna Broslo, Broslo ni yang best ni ya, sebab belakang tu dia ada, depan tu ada size ET tube, Rouse tube, chest tube, CBD tube, apa lagi tube yang you nak apa-apa tube lah you nak ada kat situ. Ubat pun dia ada semua. Bolus nak bagi pun semua dah ada. So you just flip and then just tengok je. Okay, tak payah nak susah-susah. Tapi kalau you rajin you nak calculate pun boleh. Guna calculator, guna buku Franshan tu kira. Okay. Now IV line memang standard dewasa dengan kanak-kanak memang kena dua lah. Okay. Kalau tak dapat guna IO. IO biasa kan? Okay. Hi Shah. Morning.
Sorry.
Oh, I think I'm going to overtake your time. Okay. So bagi fluid, okay. Kalau ikutkan yang standard dulu, dia bagi 20 ml per kilo. But now we don't give 20 ml, we give 10 ml and then check balik patient. Because 10 ml is 1/8 daripada isi padu darah pesakit. Jangan bagi 20 ml. 20 ml tu ialah 25% of your blood body is a lot. You akan cause bleeding lagi. Okay. Blood product biasa kita sama. Bila you bagi Paxel, you kena fikir. Saya bagi Paxel ni, Paxel saja, red cell saja. Dia tak ada FFP, dia tak ada platelet. Dia tak boleh cause coagulation. So if you think the patient bleed a lot, you must replace platelet dengan FFP. Okay? Sama kan macam unit massive transfusion protocol kan? So for children also, we will try to create one, but I don't know when. We see when the adult one runs well, then maybe ikut belakang lah. Okay? Because it's not dia blood bank tak biasa dengan dewasa. Kita tambah lagi yang pediatric, dia lagi pening. Okay. Okay, so kalau patient bleeding, kena stop bleeding. Stop bleeding dengan gamji tu untuk first aid okay. Tapi second line dia kena tutup kan? So kena panggil surgeon. Okay. Okay, GCS okay tak? GCS okay tak? Tapi yang tak okay, yang post-call tu GCS tak okay tu tak apa. GCS untuk kanak-kanak sama macam dewasa except untuk verbal dia lain sikit. Eye sama, motor sama, verbal dia lain sikit. Okay. So kalau budak yang dah boleh bercakap, contohnya 5 tahun, ni boleh tanya dia, adik sakit kat mana? Sakit kat sini. So that is actually appropriate. Okay. Kalau budak 2 tahun, dia mungkin cara dia communicate dengan mak dia menangis saja kan. So kalau mak dia kata tak apa dek, mama ada kat sini, lepas tu okay, tu maksudnya consolable lah. Mak dia dah pujuk dia dah boleh terima kan. So that's consolable. Kalau dia menangis saja kan, make sure it's not because of pain lah. Give some analgesia. Kalau melepas daripada tu masih menangis tanpa sebab, everything whether it's actually low GCS. Okay. Okay. Correct, right? This one. Okay. So you've got fitting. You have to think whether this one is head injury. So macam patient hari tu, yang patient yang datang R2 hari tu, budak tu cerita dia senang, duduk tengok TV, jatuh ke depan, lepas tu terus fitting. Fitting tak berhenti-berhenti, mula-mula status lah, dia punya fitting tu considered as status epilepticus. Tapi sebab dia ada trauma, bila kita buat CT kat patient tu, Dr. Ratini buat CT kat patient tu, nampak ada head bleeding kat dalam otak dia. Okay? So there's a cause of the seizure is a bleeding. Okay, so when you see a patient ada fitting and there's trauma, you should think whether this one is due to bleeding in the brain. Don't say it's epilepsy. Unless patient tu dah confirm epilepsy, memang selalu suka fitting dan jatuh, then it's different story. You may or may not do CT to those patients. Okay, now vomiting. Agak berapa kali vomit you kata kena CT? 2. 2, 3, 5, 6. Okay, what about pediatric? How many times vomiting then you feed CT? 1 time. No, cannot be less than adult. 2 times. No, 2 times is too little because the child cry, then cry and then vomit. Then like mama bagi susu, dia cry and then dia vomit lagi sebab dia sakit kan. Dia cry kan. So for children, right, we don't use number of times of vomiting as a reason to CT. Okay, we look for other things because children vomit for a lot of problem. You pasang BP cup, dia menangis, dia vomit. Okay, you tengok dia punya GCS, kita tengok dia punya injury kat mana, then we feel the head ada fracture ke, and then we pick up. If let's say the vomiting is really worrying, then we do the CT. The main reason for this is because budak kecil, organ dia masih membesarkan. So kita tak nak CT banyak-banyak sebab nanti dia banyak radiation. Okay, kita nak ambil concern untuk radiation. CT pun kita cakap dengan parents. Risiko untuk buat CT untuk anak you dapat thyroid cancer masa dia usia lagi besar, lagi tinggi daripada budak yang tak pernah CT. Bla 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 bla. Okay. So what rules we use? We use pekan traditional. Oh, morning Dato'. Morning. Yalah, aku nak giveaway lah. Okay, so pekan is the standard one. You all heard about pekan, you can look it up. Predict is the new one that came out 2021. This is for patients with head injury tapi dia ada special punya. Contohnya patient memang ada BP shunt. Dia fitting, lepas tu dia jatuh and then you nak CT ke tak. Use one, use predict lah. Okay. Okay. So exposure dah cakap dah tadi, patient badan kecil tapi kulit banyak, so dia akan cepat sejuk. So make sure that you cover the patient after you examine them. Okay. So that's it. So you punya tips for tubes. Ni kalau nak guna kira-kira jugalah. Kalau nak guna prostor, guna prostor. Kalau nak guna kira-kira, guna yang ni. Okay, ET tube size very easy. Ambil usia dia, bagi 4 campur 4. Dapatlah size ETT. Okay, tapi ini formula hanya boleh guna untuk pesakit lebih daripada 1 tahun. Kalau pesakit kurang dari 1 tahun, kita guna prostotic. Okay. Dan ini ET tube yang tak ada cuff. Kalau katakan ia nak guna ET tube yang cuff, tolong tolak 0.5. Okay. Okay, macam mana nak tahu berapa dalam nak masukkan ET tube tu? Ambillah size ET tube tu kali 3. Dapatlah kedalaman ET tube tu. Lepas tu dah masuk ET tube, doktor kata masukkan rice tube. Macam mana nak tahu size rice tube? Ambil ET tube tu kali 2. Dapatlah size rice tube. Lepas tu doktor kata, patient ni ada pneumothorax dah, aku nak masuk chest tube. Macam mana nak kira size chest tube? Ambillah ET tube tu kali 4. Cara 1, 2, 3, 4. Habis cerita. Okay, boleh. So budak 4 tahun, ET tube size. Cepat-cepat matematik. 5, bagus. Kedalaman ET tube tu? 4 kali 3? Ada? Berapa? 5 kali 15, bagus. Okay, chest tube size berapa? 20, very good. Pass matematik semua. Okay. Okay, X-ray, chest X-ray, pelvic X-ray boleh buat. E-pass dah biasa kan? Okay. Kalau patient yang head injury memang buat CT brain. Kalau katakan injury yang kat dalam ni, biasa kadang kita ada juga role of doing CT thorax, abdomen and pelvis for patient. Because sometimes bila you buat ultrasound E-pass, you dapat free fluid. Okay. Tapi free fluid tak maksudnya semestinya kena operate. Because some children memang dia physiological, they have a bit of free fluid abdomen. So you have to discuss you punya past finding dengan surgeon. Okay. And then itulah yang saya cakap dah, LARA. As low as reasonably available. That means guna radiasi yang paling rendah sekali. Okay, jangan suka-suka kita scan kepala sampai ke bawah. Maknanya injury tu pada jari dia je. Okay, sebab nanti dia akan dapat kemungkinan dapat kanser lagi tinggi. Okay. Okay, so ABCDE biasa, ample biasa, head to toe, back to front biasa. Okay, skip. Next one. Okay. OSCC, siapa yang dah pernah pergi kursus OSCC? Satu saja kat belakang, itu pun penceramah dia. Yang tu pula moderator dia, apalah, say man. Ayo, kena beritahu Dr. Juju lah ni, tambah lagi kursus. Okay, so OSCC, kita biasa think about child maltreatment. Sebab budak dia kecil, kadang-kadang tak pandai komplain. Dan untuk setengah budak, kena pukul tu adalah benda biasa. Saya pernah ada jumpa patient, adik kenapa ni? Ada kesan hanger kat tangan dia. Adik kenapa ni? Kena pukul. Dengan siapa? Ayah. Kenapa ayah pukul? Sebab adik nakal. Biasa ke? Memanglah sebab adik selalu nakal. Adik tu dah terima kena pukul tu sebagai normal. Padahal kita tahu kalau budak nakal, teguran dia boleh diberikan cara lain. Bukan untuk pukul dengan hanger. Okay? Boleh ya? So you can tahu. Setengah tu macam kat HKL biasa kita dapat tahu lah. Hospital shopping. Hari ni Selayang, esok Shah Alam, lusa Ampang. Dah gaduh semua tempat sebab nak buat laporan polis, dia datang sembunyi kat HTA pula. Okay, ada patient yang pernah spiral fracture, Selayang, nak admit, nak buat polis report, lari dari sana. Datang kat kami ada bekas-bekas plaster lagi. Simen, POP tu ada lagi, dia buka sendiri. Lepas tu dia katalah, oh sebenarnya jatuh masa main monkey bar. Bila tengok x-ray tahulah ni bukan jenis. Budak tu dalam usia 3 tahun, 4 tahun lah. Tak pandai cakap lagi. So kita tahulah kes macam ni. So bila tengok alamat, kenapa ada batu pay apa-apa? Kau lah hospital Selayang. Ada absconded. So kadang-kadang dia dapatlah cerita dia. Tadi kan dia kata jatuh monkey bar kan. Jatuh monkey bar is not spiral fracture, is transverse. So bila tengok tahulah cerita ni not the same. Okay. So how do you know? So yang patient yang tadi yang kes yang head injury tadi kan, yang cerita yang status epilepticus tu, kita tahulah sebab bila tengok badan dia ada luka lebam, hari ni warna hijau, yang ni warna kuning, yang tu merah-merah sikit. Kita tahulah yang ni pukul hari Ahad, yang ni pukul hari Sabtu, yang ni pukul hari Isnin. Lain color, lain hari pukul. Okay. Biasa kalau budak jatuh, dia sekaligus dia jatuh, dia akan injury dia sekali kan. Dan parents akan bawa teruskan. Jatuh hari ni, kakak macam ni. Okey lah, logik lah. Jatuh double decker, kena kat meja, lepas tu kena kat kerusi, lepas tu jatuh ke bawah. Ayo. Okay. Okay. So yang baby hari tu ada subdural. Baby hari tu ada subdural dengan ada retinal hemorrhage. Retinal hemorrhage ni memang kalau mata kasar tak nampak. Tapi biasa kalau kita buat fundus tengok mata dia, akan ada pendarahan dalam mata dia. Sebenarnya baby ni baby shaker syndrome, ada shake, lepas tu dia koyak-koyak dia pergi kat dalam. Okay. And then yang ni ya, kalau kita kata skull fracture usually most of the time we tanya lah, tengok history dia correlate ke tak lah. Tapi rib fracture tu yang tadi saya cerita tu kan, rib dia biasa tak patah kan, dia lentur. So kalau fracture is very mega soft. Okay, don't forget your child act. Kalau rasa macam risau, parents larikan diri, tolong masukkan selamat. Atau kalau tak refer awal, bagilah excuse macam-macam lah. Oh, kejederaan macam ni ya, dia mungkin ada ni, so kita kena siasat macam ni. Tapi bukan sebenarnya siasat tu siasatan polis, tapi cakaplah cara lain. Bukan kata nak tipu, tapi tipu sunat. Sorry ya, bulan puasa. Sebab sebenarnya, because kepentingan bukan untuk parents, kepentingan untuk siapa? Budak tu kan, sebab budak tu dah kena belasah dengan parents dia. You nak protect that child. Okay? So gunalah cara macam mana tu nak selamatkan budak tu. Sebab kalau parent ni bawa lari, kemungkinan esok datang forensik dah. Datang kat kita dah. Okay? Okay, so apa yang beza? Ingat balik yang ni semua is a summary lah. So dah cakap attitude memang senang nak cabut. So bila your anchor, make sure anchor properly sebab biasa baby dia banyak kan dia punya secretion kan. So kalau you take, you kena check often sebab kadang-kadang dia senang dia kena cabut. Dan ingat tak tadi saya kata kedalaman attitude kan. So beza antara size attitude yang berbeza, dia 1 cm, 2 cm, dia dah boleh terkeluar. So be very careful of your this one. Okay, banyak kali dah kita intubate, lepas tu bila datang, can hear baby cry. So kalau baby cry, attitude tu kat mana? Sama ada dah terkeluar atau masuk esophagus. Okay, so kena intubate lagi sekali. Okay. Ya, so yang satu yang paling bawah sekali tu orthopedic injuries tu biasa tulang kanak-kanak ni dia tak bentuk sepenuhnya. So very difficult for us to find injuries like green stick atau epiphyseal. If you're not used to it, please refer. Oh, ada orang nak take over lecture ke nak tanya soalan online? Sorry, ada orang berbunyi. Okay, IV line, alah tak adalah susah sangat, sama je, kena cari je, tepuk-tepuk sikit. Ni pegang betul-betul. Ayah jangan geleng-geleng kepala, boleh saja. Okay, can lah? Okay, lepas tu yang gastric dilatation tu make sure you masukkan rustral to aspirate lah. Make sure dia tak ni. Okay, we almost finish already. Okay, so I think I gone through all this one. Okay. Thank you. Any soalan or not? Questions? Okay, lepas daripada ni balik check you punya pediatric corner tu, make sure barang cukup Okay, boleh ya. Okay, and then essential is don't freak out. It's a child. Usually they don't get bad traumas. When they do get, they get very, very bad ones. But that's not often lah. So if you're tip top of your adult trauma, you could be quite okay. Okay? Can
Yeah, thank you very much, Dr. Lim. Sekarang saya jemput Profesor Datuk Sri Dr. Abu Hassan untuk menyampaikan sedikit cendera hati kepada Terima kasih Datuk Sri. Sekarang tiba masa untuk kita jemput penceramah kedua. Jadi saya perkenalkan sikit. Penceramah kedua kita ialah penceramah kedua kita tak lain dan tak bukan ialah Dr. Shahjahan Muhammad Yusof. Jadi beliau adalah seorang trauma physician daripada Hospital Sungai Buloh. Dulu ex sini dulu semua mantan-mantan dari sinilah. Jadi sekarang sudah berpindah ke Hospital Sungai Buloh. Jadi beliau ialah actually pakar perubatan kecemasan, emergency physician dengan subpakaian trauma medicine. Jadi beliau telah completed 3 years subspecialty program. Salah satu tahunnya di Alfred Hospital in Melbourne. Jadi sebenarnya beliau juga adalah supervisor saya semasa saya membuat saya punya subkepakaran. Jadi kita jemput Dr. Shahjahan untuk menyampaikan tajuk hari ini iaitu Trauma Transformation and Expectant Trajectory. Okay, kita berikan tepukan.
Terima kasih. Assalamualaikum semua. Salam sejahtera. Terima kasih banyak kepada Dr. Ibrahim. Very kind words and congratulations on being able to organize successfully the trauma week di PJA ini hari terakhir ya. Okay, I think that is quite a critical intervention lah, terutama sekali dalam keadaan sekarang ni where a lot of education time has been kind of lost after the COVID. So it's good to catch up again. Yeah. So first of all, I'd like to thank the organizers for having me. It's an honor to be back in my ex-boss punya dewan. And we have the honor to have our Professor Datuk Abu also with us to give the final lecture after this. So this is going to be just a little light, tak berat sangat. Dan sesuai lah dengan bulan puasa ni ya. So ringan-ringan mesti. So just hang in there and just enjoy the lecture. It's going to be a little bit of what the history of emergency medicine pertinent to trauma was before, where we are, and likely, hopefully, where we will be heading to. Yeah. So maybe some of you have seen some parts of this lecture, but just for the benefit of all. So a bit of background. Trauma is a problem, yeah. So it causes a lot of premature death. I mean, I'm not being biased because we are trauma physicians, but then yes, diabetes, hypertension, ischemic heart disease cause death, but timely, yeah, when they are very old. However, the only one disease that takes your life away when you're at your peak is trauma. Yeah, it's the highest cause of premature death, but we don't see it as a disease because it is non-communicable. Yeah? But however, there are a lot of initiatives to try and bring up the awareness of trauma death, yeah, among the young. Every one of you, I am very sure, knows somebody who is young and has gone a very unfortunate event. And you may say so that you are lucky if you died. Because if you didn't die, you'll be debilitated for your entire life. And that is just not suffering to you, to them, but the family. So you can imagine the social impact at the back of it. Yeah. So it is part of the Sustainable Development Goals of WHO to reduce trauma death. So this initiative has been going on for the past 10 years for Brunei, Singapore, and Malaysia. So to drop trauma death on the roads by 50% in 10 years. Yeah. So kita masih jauh lah. Matter of fact, mungkin silap trauma death increasing a bit instead. Yeah. So just to put a bit of perspective, I know we don't like data, but I kena tulis lah. Lagi bos kata apa tak ada evidence base kan. So I tulis lah sikit-sikit. But I like to just highlight one out of here. A lot of people die. More than 6,000 people die a year. One aeroplane, kalau penuh dengan apa, all the stewardess and all that, 400 orang. And one crash kills 400 people. And every one of us will know about it. But every year, more than 10 jumbo jets crash. Average more than one a month. On our roads every day. That's the perspective. So it is a lot of people dying. For every one of us, our life expectancy, God willing, will be like panjang lah. Tapi secara average-nya, females live longer than males. So this is a very unfortunate event lah. So, however, that is the fact. So at average, kita imbangkan 75 years old. Our expectation. If you calculate at 28 people who die every 100,000 population, every year, all of us have a 2% chance. All of us know 2% chance lifetime accumulated risk to die on the road. From the moment you're born until the moment you die, 2% is your chance to die on the road, not to be debilitated, paralyzed. So that's the reality today. That's where we stand now. So important to do such specialty in trauma. Master campaign sikit lah, sorry, All right. So this is a little bit background. Ministry of Health has been there for early 60s, and those days the emergency department used to be called casualty department. So kita pun jadilah mangsa casualty. But over the years, there were a lot of improvements that came in. What you know today probably is the works of people before, and one of them is Yang Berbahagia Professor Datuk Seri. So he has been the father of emergency medicine, who has brought in a lot of fundamentals and structures. So, ada dah matan dah. So, however, and after Dato' Abu, there are a lot of other people who come and still are doing. So, but if we can put ourselves back before, ED wasn't what it is today. It was just a place. You put a patient and it's literally just to sort and identify. You identify, dispose. Okay, yang ni, macam surgical patient. Okay, panggil surgical, hantar sana. Oh, yang ni mungkin stroke, not sure. Tak apa, hantar dulu. Like that. Just send only. It's just a place to come and dispatch. Post office lah. Dulu. Sekarang pun orang kutuk-kutuk kita macam post office. Tapi at least post laju lah. So the first batch of emergency physicians graduated early 2000. Ini bukan emergency physician. Ini yang senior OTA MA kita. Yang daripada hospital Kuala Lumpur. Okay. Zoom. Okay. So early part, kita had to focus on many fundamental things, services. Contohnya establishing triage and clinical zoning system. So triage was very important, sort out dari depan sekali. So kita tak ada banyak doktor. Emergency medicine physicians also first batch came out 2002, 2002. And from then this infrastructure started coming in. So MAs waktu tu dilatih how to analyze, how to visualize, how to identify emergencies by primary triaging, then come secondary triaging. So ini benda-benda asas lah awal. So this is the triage counter kat depan, depan ni. So di sini triage counter modernized sikit, tapi tak modern, ni gambar lama sebenarnya. Yeah. You can see siapa kat belakang counter if you all recognize EP kita yang lama. So this was the drop zone area. So there was a lot of drop, triage, secondary triage, disposition, treatment. So the basic fundamentals were coming in. Then there was pre-hospital care at that time. So pre-hospital care dulu scoop hantar. Kalau kita ikut sejarah dulu dia guna kereta kuda tau. So kereta kuda dia put on the wagon and sell. Eventually it became St. John Ambulance. So dia ada van, lepas tu dia ada beacon. Then dia ada orang-orang yang terlatih dalam bidang tu. So it was community-based ambulance services. Then over time, it started becoming a Ministry of Health Intervention, 999 system services. So jauh lah perjalanan kita sejak dulu. Lepas tu dari segi perawatan. So emergency care was provided for all medical and also trauma patients. So kita ada specific zoning. Kita ada zon hijau. Kita tak ada lagi nurse, okay, satu nurse jaga semua. Atau macam dulu-dulu kat distrik, satu MO jaga habis semua, satu hospital dengan ED dia sekali. So it became more dedicated. Nurses yang jaga green, yang ni yellow zone. Yellow zone pun ada high-end system monitoring. Nampak tu atas kat table tu. So that was considered state of the art in the year 2005. So boleh ada monitoring. This is our yellow zone. So it started improving slowly. Lepas tu a lot of our resource went to the most critical area. Mestilah if you have RM1, $1 to spend, where will you spend it? On your girlfriend or on your mother? Mestilah mother kan. So we spend it on the mother lah.
Girlfriend's mother.
Saya anak yatim.
Investment.
So tengok pada dulu. So you have this ultrasound machine, apa ultrasound? Ini ramai minat ultrasound. So ini ultrasound. Ultrasound machine yang paling lama. This was the first ultrasound machine I remember kita guna kat research kat sini. That one was macam yang ONG dulu. So at that time was already started initiative bedside point of care ultrasound test.
That looks like me.
Yeah, that is. Lepas tu ada wall mounted X-ray for trauma. So this were early initiative. You will think this is long time, and until today some places still don't have this kind of initiative. So daripada dulu, so a lot of focus put where it was important, and then infrastructure that was put in to manage the patient also called the structure mirrors the service. Even at that time. This I pinjam lah bos punya slide. Sorry, I didn't know you were coming. Tapi lucu I letak kata sini.
Tanya. Lucu lah Bapak.
So this is what golf swing ergonomic. Sebab bos kita dulu suka main golf. So the logic is your turn lah, it's your swing. So basically the people don't move. The equipments are arranged around you, so it helps and facilitates the speed of intervention, the process accuracy, and the dynamics of the team play. So perkara-perkara ini menjadi asas daripada dulu. So then, next slide. Yang ni siapa kenal? Ini pun recent. Yang ni mungkin you all will think is a recent photo sebab COVID semua pakai topeng. Actually, this was in early 2000 sebenarnya, gambar ni. Dia boleh jangka dah akan ada COVID. This is, who can guess who is that man at the end of the bed? Ni Datuk Dr. Mahadab. Waktu tu, dia jadi team leader. So this was simulation.
Rambut really.
Dia lama je.
Just for the record, Ibrahim said that. So the concept of team approach tu ada. Ada MA, ada nurse, ada doktor. Ini bukan pesakit betul lah, tapi dia simulation to simulate. So that concept yang ni lagi satu innovation. Innovations were put in very early in emergency medicine. So this is an equipment yang Datuk Seri Abu Hassan design and call it Nina Clef. Nina nama anak dia lah. So it's an external pelvic finder. So these were earlier times lah. Ramai mungkin didn't have that opportunity to see this, yeah. But that was how we came. And on the history side, we grew and we became accident and emergency department. Yeah, accident emergency. Tapi yang tu pun tak betul sangat juga. Mengapa accident saja? Kan? Kadang-kadang trauma is assault, is fall, is homicide. Taklah accident, kecederaan saja kan. So it eventually grew to emergency and trauma department, which is likely a bit more appropriate lah yang kita kenali sekarang ni. 15 years later, daripada 2002, sejak kita graduated the first group of emergency medicine physicians, we are able to graduate the first group of trauma subspecialty physicians in emergency medicine. It took us 15 years. Nak kata lama ke tak, I think it's a reasonable amount of time. Because the best only came later. So I verbalize my thoughts. 15 years I think is reasonable time. Many other countries took more than 20 years to come up their subspecialty badges. So I think we are okay. Tak ramai tapi sikit. So Dr. Ibrahim is one of the badges yang trauma patient, is a trauma service lead at hospital Kuala Lumpur. ED. Now we have 12 people in training in subspecialty, and we hope to see more. We like to have people. Dia lama lah sikit 3 tahun. So cuma yalah subspecialty is a different ball game, but we encourage more people to move, especially the younger generations. Younger meaning myself included lah. So dalam membentuk perkhidmatan, we feel that there are 3 very important structures. These are what I personally call the pillars. It's not limited to this, but these 3 are very important. Infrastructure, clinical approach, and systems. You cannot do one without the other. Kalau a lot of us will think, okay, subspecialty, clinical approach, go and get trained, you can do all sorts of things in the world, which the world also never thought exists, you can do. Lepas tu you balik kat negara you nak buat benda ni semua. But you don't have the infra. You don't have the system. You don't have the team to support you. Were you any better than before you left? Did you able to benefit your society more than before you left? Matter of fact, less, because you should have just stayed here and benefited them during the gap of time you were away. So it's important that all 3 things go together, and this is important for our doctors to understand. It's not just one, it's everything. And you are responsible to develop it. Nobody will do it for you. It's our job. So let's talk a bit about infrastructure. So we have seen where we come from, where we are, and today, God willing, we have had some facilities that are able to provide certain concepts, where you have an infrastructure that grew from what it was before to something that you have all in what we call as the damage control resuscitation suite. So the principle, the infrastructure should mirror the service. So it's designed in a way to see how you function, how you work, what you need during your resuscitation for trauma patients. And the facility is designed to cater for you. So it's an all-in-one stop lah, contohnya. You have everything here. What is the worst thing you don't like during resuscitation? Kata you are team leader, you order something kan, you order, okay, ambil line, so some special line lah, double lumen Mac arrow line, contohnya. Lepas tu your team nurse PMA hilang, nak pergi cari line tu kan, hilang selama-lama, tak balik. There is no close loop communication there. And then you are not sure. Dia pergi cari benda tu ke? Sambil-sambil cari dia jumpa member ke? Atau benda tu habis ke? If there's no close loop feedback, Then you were wondering, you want to send another member of your team. Dah lah tinggal skeleton je, 2-3 orang je. You send the other one. Yang tu pula, you seorang lah. So, how to solve that simple problem? Everything is in one area. Nobody lives. It's an all-in-one suite. So this is just a simple way I want to explain how the structure mirrors your service needs. And banyak lagi lah contoh-contoh. So in this area, you ada blood pun ada dalam tu, warm blanket, warm fluids, television ada kokot, sambil risas you want to watch Netflix. I'm just joking on that one, by the way. That TV we'll talk about later. And then there are ergonomics involved in it. So the visual screen that you see is actually a duplicate image of your ultrasound machine, a duplicate image of your video laryngoscope and your bronchoscope. Why we put that? That is for the team leader. Perasan tak? Bila ada resuscitation patient, everybody kerumun keliling kan? But nobody is really functional. It's the raw truth lah. Sorry to say that, but it is. I mean, I'm sure we all experience that. And at the end, you don't need that. That's the wastage. So the team leader only needs to see what's going on from the far and safely. And people, the team needs to know. The ones who are trying to learn, we cannot stop them. They need to learn. Everybody needs to learn. So you have a place where you can watch from far and learn without interfering with the patient. So that's where the screens come in. And it's also recorded. So for the documentation processes and whatnot. So this is an incubation process. So this is my penyelidik trauma. Nama dia Tuan yang berbahaya, Tuan Zul Faiz. Dia penyelidik kita lah. So everything it goes through him. So tengok, he's trying to show a demonstration of incubation. Nampak? This is a video learning notebook. That's the screen. That's a worker code. So dapat 2 screen dalam TV. So the observation group dia ni boleh tengok kod edema, boleh tengok what is VL, what is kumak lehan 1, 2, 3, 4, how to see the tube going in, and he has his own screen. And kata dia fail intubation. Tak adalah team leader panic. What happened? What do you see? What was there? Nothing. You see the problem itself, you can guide your team. The structure mirrors your service needs. Okay. Ultrasound. Okay. Semua nak tanya ada free fluid, free fluid. Tengoklah sendiri. You see yourself the free fluid. You can tell your team, okay, go down, go rock, go slide, go up, everything. And again, the same concept. That's what the screens are. You save time, improve efficiency, and most importantly, this is total quality management for patient safety. You have multi-tiers of, it's a simple intervention, but it helps. So ramailah kita dapat pelawat yang datang untuk memberi semangat, termasuk as we can see pengarah Deputy DG, Dato' Abu Sukif, and then memberi idea-idea dan kongsi dan memberi semangat-semangatlah kepada pasukan yang telah bekerja dan usaha membina, sebab bukanlah mudah sangat, a lot rintangan-rintangan dan sebagainya. So it's always a challenge to develop something. If you're doing something and it feels very difficult, that means it's very good. That means you're on the right path. If you're doing something and it's too easy to accomplish, stop and ask yourself, how come? Something wrong. So life is such. So kita dapat penghargaan, alhamdulillah. Kita dapat anugerah inovasi juara negeri Selangor dan juga juara peringkat kebangsaan Kementerian Kesihatan pada tahun 2020. Anugerah juri. So this we dedicate to the hard work of everybody in the trauma services. Clinical approach. So here is where what everybody talks about and thinks this is the most important. It is extremely important, but it's not the only thing which is important, as we discussed. So here we train specialists to be subspecialists. We train MOs to be very good MOs. We train nurses to be very good nurses in a specific field, trauma. Before, we couldn't afford this. We didn't have the luxury to. Means you're a nurse, you must do everything. Because nurse pun tak cukup. Now as we grow on, we can afford to have nurse yang pandai trauma. Like kita ada headache trauma, MA and nurses. Now we have sub-trauma, and etc. So these are the programs. This is a structured 3-year process for emergency physicians to embark into. This is the trauma patient subspecialty program. That's emergency trauma care down there. So if you're not sure which one to take, so the last option seems to be pretty good. Yeah. This is our EDEC nurses. EDEC nurses. So EDEC nurses semua happy. They're very happy. Yeah. So they come. They spend about 4 months with us. So EDEC SEM 2 pre-hospital and trauma both comes to Sungai Buloh. Yeah. So dalam improving your clinical approach, a lot of documents you have to take. Yeah? So this is one of the programs where we created a manual for cadaveric workshop. Siapa yang tak suka mayat tu, this is probably not a good workshop to attend. Yeah? So you take the cadavers, and these are fresh cadavers, very well professionally embalmed, and this is an opportunity you have next to real. You are managing human tissue, fresh human tissue, to do the procedures, and you have that room for error without causing morbidity. There is no more morbidity than that. So the bodies are donated by whom we call the silent mentors. So they donate their body to science, and this is the cost that we conduct once a year. It's a very expensive cost to conduct. Yeah, cost us at least 60,000 to 70,000 per course, but participants pay RM1,000. We subsidize it. Yeah? Dan nak bagi free, saya kita appreciate lah kan. So we charge a little bit, so we can take 20 candidates every 1 year. So look out for it. Here's where you get to do your cricothyroidotomy, lateral canthotomy. So subspecialty candidates for trauma are diwajibkan. And you do resuscitative thoracotomy, buka dada lah, tekan jantung dia lah, macam-macam. So here is where you do all this kind of advanced trauma resuscitation skills. And of course the basics also lah, suprapubic catheterization and things like that. Okay, so damage control resuscitation. This is another forward-going direction, a mainstay of trauma resuscitation care today. I won't go very much into it. Basically, it has fundamentals, and many of you will be able to understand this better, I think, in the next lecture. Okay, just to understand damage control resuscitation. Okay, dia kata permissive hypotension. What does that mean? You drop the pressure down, but don't drop until the pressure is unpalpable anymore. Drop by the level of the target. Okay, so if too high, you drop. Why you drop? Higher the pressure, you take a water pipe, you on the tap, faster lah the water finish. So that's your blood, literally. So you just kind of slow down that tap. It's very simple principles. And then you want to off that tap also kan. So you want to put a cloth in front, the thrombose that tap sikit, bagi tutup. So kalau pressure dia kuat, senang tak nak tutup? Susah. Pressure dia lemah, senang tak nak tutup? Senang. Want to put plasticine kat depan tu. That is damage control. Right? And nak guna plasticine ke, you nak guna gum ke, chewing gum ke apa? What material? Tissue paper ke? That material is called hemostatic agents. A better material to assist for you to stick and thrombose. So I give you one case. This pakcik, dia umur dia 60 plus. So he was guna grinder, dia kerja, dia grinder. Some of you may have seen this, some maybe not. So the grinder tu ada blade. The blade pecah. Blade tu is very fast and it's very hot. It went right into his left shoulder. That shoulder went through his clavicle. So they fractured that clavicle. Behind your clavicle is what? Okay, this is going to be light, so it's not a quiz. So I answer. I answer. Ada subclavian artery, ada subclavian vein. These are major vessels. High pressure, high volume, 7-8 inches from the altitude. So this high pressure vessel, bila clavicle pecah, we usually leave that sharpener dalam tu, tapi sebab panas, the reflex is what, pakcik tu ambil, tarik lah. Bila tarik, it starts to bleed. So he comes in with a blood pressure lebih kurang 50-60 macam tu, systolic. and is bleeding torrentiously. So when I say torrentiously, maybe I have to show. Okay, tengok. So ni one of my welcome case lah masa balik daripada Australia, welcome you with a nice case. So this is my elbow, so I minta dia compress, relax, chill. I told him, he got very upset. They said, oh, bleeding. I said, yeah, when you get cut, usually you bleed, that's a problem. So you bleed, nampak? So it's a tap. There's easily more than 50% immediate mortality for these cases, what we call a junctional arterial hemorrhage. This is junctional bleed. Junctional bleeds you cannot tourniquet. There's no how to tourniquet. Tourniquet, thorax, packing, hemostatic invasive deep tissue facial packings. Yeah? When we drop the pressure, we put blood, drop the pressure and maintain it to not drop, increase the pressure to 70 systolic. Why at 70 systolic? In case I am not successful at this, I have a window to play. Yeah, it doesn't drop to PEA lah. It drop back to 50, 40, 50. Yeah. So that's permissive pressure control. And what you have inside there, that gauze you saw, was actually chitosan powder. So it's a hemostatic. So it's engulfed into a ball. How you make that size? Because I saw the wound before that, so I can gauge. Then I pack it into that wound and I press it. Yeah. So lepas kita buka that wound, you get successful hemostasis and hemorrhage control in this patient. Yang batang ni keluar ni clavicle. Potongnya. So what happens? You move it around to provide deep tissue hemostatic suturing. You leave the packs in there. You kind of get a blood pressure which tends to normalize. It's too high for my happiness anyway. It just naturally begins because pain anxiety. And the patient goes for, now you hand it over to the surgical team. Surgical repair. That is resuscitation. Whatever you do, that is resuscitation. This is repair. So this picture was achieved after 4 days lah. Dia very happy. Tangan ada no neurology. Was lucky. He was discharged well. So this is damage control resuscitation. Secara up. And in many more instances lah, banyak lagi situasi lain. Just give example lah, bagi kita mudah belajar. So what is it? This is interventions of regional anesthesia for pain, for reduction. Kan kita nak buat reduction kan, kita nak buat irrigation and all that. Patient will be screaming and shouting. Yeah? So that is not very nice lah nowadays. So we try to ease their pain dan sebagainya. And when you ease the pain, you also reduce the systemic inflammatory response syndrome. Pain itself is an inflammatory cause. Yeah? But the body is all connected. You know, when you're in extreme pain, you have physiological changes in your body. So manage that pain too. Yeah, it helps in outcome and recovery. So this is how you manage, and then you boleh buat macam-macam kat dia. Letak jari dalam lutut dia lah dan sebagainya. So that way you can really wash out. So andai kata your subsequent team pun delay lah 8 jam nak buat off, esok lah, next week bagi appointment lah apa. The success of that operation is higher because you have debug the germ. Solution is the dilution is the solution to pollution. Debulking, that is very important. First stage of, and this is whose job? This is our job actually now. We are the front line. We are the ED. Yeah, it's our job. So that bone is taken out from that wound. Can that be done in a normal day? So again, this can be done with the interventions of regional anesthesia. Yeah? Okay, this 14-year-old boy, dia duduk senyap-senyap tepi motorcycle dia. Of course, you curious. 14-year-old ada lesen tak? So he was playing his motorbike. He parked the motorbike. One ton lorry, one ton lorry 1 ton, datang dan langgar dia. Langgar dia kena kat chest lah, saya rasa. Then Mahamas somehow got one ambulance there, took him all the way to Sungai Buloh Hospital in a 45-minute ride. Sampai kat triage counter, witness arrest. He was awake and collapse betul-betul depan tu, macam Tamil movie, ya. But this is real. So collapse. So this is a classic case of witness traumatic arrest. So terus dimasuk ke dalam damage control resuscitation suite. As you enter, bilateral finger thoracostomy is done, CPR commenced, and after 2 minutes, there is no return of spontaneous circulation with evidence of traumatic blunt, either blunt or penetrating thoracic injury. So I proceed to a resuscitative thoracotomy. Means you open up the chest, you go to the intervention area for 3 objectives: stop the hemorrhage, access the heart and remove any form of pericardial tamponade, access the heart, and thirdly, provide cardiac compression directly. These are the 3 interventions that you do for the purpose. Andai kata dia cardiac arrest sebab obvious bleed at the leg, sampai habis bleed, janganlah dibuka dada dia. So you must have evidence that is from the thorax. So let's share some video on this. The video. Some may say a little bit gruesome dan sebagainya, but this is real life, real time resuscitative thoracotomy. Can you imagine how to do this? Can we just do this on the bedside? I can't do this alone. I need MA yang terlatih. I need nurse terlatih. I need MO terlatih. I need infrastructure. I need to be terlatih. I need the equipment. So for you to provide a service, infrastructure, system, and clinical approach. Tiga-tiga benda kena ada. So the system, how to assess, you have to, from point of arrest, you have to be in less than 4 minutes in the heart. You cannot do that without a system. How to get everybody together? Trauma team activation. Fast. So everything is correlated to each other. Okay. So after, we can, so after, after some time, the heart beats back, and then we managed to stop this. It's a left perihyoid arterial laceration. They had a massive pneumothorax. So that was a clamp with a vascular clamp. So I tutup sementara, then the cardiothoracic ring comes in, and they do the repair. So this is the, at this point of time, the blood pressure was, I think the video was talking, it's about 90/60, the heart rate of 120, pupils reactive. So that is advanced interventions that we can do trauma. Itu contoh-contoh damage control resuscitation. So we never do this before, 15 years ago, but we do this now. My question to you is, what can you do in the next 15 years? And that's where we should be heading. Clinical approach, other things. Taking level 1 evidence into clinical practice. We all talk about crash 2, 3, 4 sampai crash. But what do we do about crash? Tranexamic acid, how do we apply that into daily practice? It is our job to put it into articles for the Malaysian cohort of population. How us Malaysians can use tranexamic acid to use in pre-hospital care. It's a level 2B recommendation from the European guideline of hemorrhage controls. To give the tranexamic as early as possible. It should be given in the ambulance. So how to provide the guidelines? Convert evidence-based into clinical practices. Nak cerita lagi satu. Okay. This guy, dia pre-hospital, talk about trauma pre-hospital. Ada bangunan runtuh some number of years ago, 2016, dekat Mid Valley. So this bridge, during lunchtime, collapsed. Ada ramai worker. So good thing was lunch, most of them were not there. But one unfortunate worker got his legs trapped. Bawah tu ada sungai. So the bridge collapsed and he was trapped. He was alert. So bomba lah datang, try to use the hydraulics dan sebagainya. So tapi dia gagal, dia guna hydraulics tu. So nampak hydraulic ni, gagal. So that was the only part they can open. So it is actually quite a risky situation. But the only way at the end was to amputate his leg. Dia stuck, leg dia cut foot. So how to amputate his leg? He's in the middle of the river under a bridge collapse. So who's going to do all this job? Tuan-tuan dan puan-puan sekalian. So this is what we have to do. So of course the trauma group has to do it lah, but definitely not us alone because berapa ekor. Dia ada So this is emergency medicine. So it is, we will lead, but everybody needs to be able to save lives, limbs and life. So that's me. So provide a proximal tourniquet, because otherwise you will bleed to death when we cut through the popliteal artery. Disarticulate the knee, disarticulate, so you don't have to put a jiggly saw. There's no space for that. So macam tulak lah, you go through the knee joints, easier. Then once you're able to disconnect the leg from your thighs, you have a tourniquet placed there. You provide a hemostatic backing. And the other good thing about this articulation is that you don't go through marrow. Marrows bleed, and when marrows are very hard to stop bleeding in out the hospital. So when you disarticulate, there's no marrow. It's end-to-end bones. Yeah. So all you need to do is control soft tissue. So you're able to extricate him after some time and take him to the hospital. So that is him already extricated, going to the hospital. Ambulance yang respon paling dekat is yeah. But you can see the team comes from all over the place. Yeah? So this is part of regionalization of response. Yeah. So he was came above knee amputation, discharged about a week from UM. So he survived. Yeah. So good for him. So those are advanced things we may be talking about. What are simple things we can do every day? The low-lying fruits. Okay. We call it the neck. Do we call it the hips? Yeah, we call it the hips once the primary X-ray shows us that the hips are open wide, And it's already too late. We have lost a lot of blood, a lot of time. Yeah. So whenever you call it the neck, call it the minders as well. In patients such as unconscious, polytrauma, high impact, pain over palpitation, the index of suspicion is a subjective thing. So whenever you call it a neck, call it a hips. It's a low-lying fruits, we call it. It saves lives. Don't do this anymore. This is simply for the purpose of diagnosis. Opening up the pelvis. Every time you open the pelvis, you open the bleeder. And then I tak percaya lah betul ke pelvic spring positive. I try lah. Registra datang, dia panggil specialist lah. Ya betul. Specialist pula try. Betul lah. Bagi tu consultant, non-stop people diagnosing the diagnosed. At the end, yang last pula doing this is the forensic pathologist. So why do? We have image guided. Do image. This is innovation. We take it a little bit in current. This is what we call the pelvic influx. This currently we are working on this with Syring, and it's a module where we use air insufflation in certain points, and it comes with vibration. And the vibration is so that you can use it longer periods without having short source. So it's still in the prototype model. This is concussion. Concussion is very favorite. So you have concussion, you keep for 6 hours. After that, dah boleh pergi toilet jalan, you hantar balik. Everything is all well and good. Is it? Have you had anybody come to you, doctor? What happened to me? You cerita lah dengan semangat. Oh, pakcik jadi macam ni, datang, lepas tu masa panjang pokok tu, pokok tumbang, kena kepala and all that. Sekarang pakcik ada kat hospital ni. Terima kasih. Like me, when they respond, terima kasih adik. Muda kan? Kalau dia respon pada Datuk, terima kasih pakcik. Ambil peluang sih. So, I'm sure you will. Half an hour later, you go back to that same pakcik, thinking, hey pakcik okay ke? Tadi apa jadi ya tadi ya? Oi, tanya balik benda sama. Check GCS full. GCS will be full. Then you start thinking that this pakcik is just being a problem, badan muka jatuh dan sebagainya. Actually no. What he's having is anterograde amnesia, which doesn't get detected by a normal GCS system. So how to get this done? How to detect the ability of the brain to lay down new memory? And that's a hypothetical function of your brain, which commonly gets injured during concussion, severe concussions. Yeah. So this is the AWPTS score. We have incorporated for the use in Malaysia. So we keep it to, instead of 4 to 6 hours, you show them 3 pictures, and then you come back in an hour, ask them to recall. Then you can detect is the ability of the brain to lay down new memory anterogradely is still intact. Then you have a score of 18 statement. Yeah? So this is simple things which we change how we work. So we have actually detected quite a number of people who had full GCS but were not able to remember things. If we discharge, then they go home. They spiral down to society. Boss asks you to do something, you know, but to not done. So you think, you know, this employee is not doing very well, you know, he lose his job. Balik rumah pula, you know, the house wife, you know, that one is worse than the employer. You know, you ask to do something, tak buat, never take out the rubbish and all that. This may sound very simple, but after 1 month of that happening, you lose your job, you lose your wife. Some people lose their girlfriends. And that social spiral could have easily been avoided if we detected it from ourselves. So we are the last safety net. Go to KK, oh, CT scan normal. Go back, Panadol, and out you go, you know. So if we detect this early, neurorehabilitation. That's the key. The diagnosis changes. It's no more mild. It's probably moderate traumatic brain injury with persistent post-traumatic amnesia. So it's not cerebral concussion anymore, you know. So that's how things change. Yeah? So in our safe to discharge criteria have changed for converted to PTA score 18, at least that's incorporated. Yeah? More is not necessarily better. Have a look at this picture. This is a real-time picture. I said that very sad looking at this. All the resources in the world you want. What you want is not here. You want how many ultrasound machine? How many ada? Dua ada kan? How many MOs you want? Penuh. How many MP you want? Full. Patient mana? Sampai tak nampak. What's going on here? More is not better without a system. You don't need more. You need efficacy. You need system. So this patient doing CPR. Alright. This is an activation system. So sebelum patient datang, surprise, I'm here. You know, it's not good lah. You know. So kalau patient walks in, you can't do much, but you must be prepared. You must have a way for everybody to come together and treat this patient in dire need. Yeah, that's what you call trauma team activation. If you call them earlier before the patient is coming, already in the ambulance, it's called a pre-hospital trauma notification and team activation. So that's what we do. So we announce in the PA system, trauma team standby, DCR1, team ETA, 1 minute. But you know something is coming. What is coming? You take your phone and wait for about 30 seconds or so. A text comes in and tells you what is coming. So that is the system to adjunct. Everybody's waiting. We kind of are prepared for what's coming. Yeah. So that's how we work here in the T0 trauma reception. So we know what's coming, prepared, and you treat accordingly. And here's the ergonomics of not having to have so many people around, but effectively people. And here, people who provide, they say trauma team or the chest tube, the leader. Yang ni MO2 lah, pergi ambil tube, pergi ambil suture, pergi ambil ni, and you kena buat sendiri. You know, while somebody else ordered to do central line, that fellow is going to take the central line also, and in between they hit each other, ada green stick fracture, needle prick injury, all that happening. Organizing. Preparation is done here. The people are doing it. We call it trauma cafe. Yang ni, the person, the patient is a customer. The circulation manager apa semua is your waiter and waitress. Team leader is your manager, your kapitan, floor manager. This is your coach. They prepare. They serve the procedure, ordered and monitored by the cook, and the customer is happy. So you realize this? Who are not involved is out of the red line. Kalau masuk ke basic, kena samat. So you get a very systemic approach, very clean. So compare this to compare that. More is not necessarily better. It's just optimization, which is better. Systems. So let's talk. How you want to get CT scan sebelum ni? Kena gaduh dengan radiologist, you know, gaduh, you know. Then after that, radiologist rasa kesian kat you, then okay lah, di atas dasar simpati, kita benarkan CT scan pray, you know. Then boleh swikel, gaduh lagi, you know. Swikel you buat esok, appointment. How you can do this? This is not the way to go for trauma. For trauma, what we want a head to pubic symphysis and CT scan in patients who are indicated, who fulfill criteria. This happens overseas. So we are happy to say it happens in Sungai Buloh, and tahniah kepada Dr. Ibrahim dan pasukan. It is now happening in Hospital Kuala Lumpur. So these are now the only two national tertiary centers that have a trauma CT PAN scan criteria, indication based. And the morbidity drops by more than 25% in all global data, minimum, when you have PAN CTs. It is also a category 2B recommendation, European Guideline of Hemorrhage Control, for early detection of hemorrhage to use CT scan in a PAN CT criteria. And just to put things into perspective, it's a 1C recommendation. PAN CT is 1B. Yeah? It's higher level of recommendation. Okay, so these are criteria for CT scans. Training, trauma life support. You go to Bintulu, dia kata, oh tak boleh kena buat macam ni. You pergi kat Sarawak, oh buat macam ni. Kat Kuala Lumpur kata kena buat macam tu. So naturally, the outcome of 3 different patients in 3 different states in this country is going to be different. Standardization of the training. Yeah? What we call trauma life support Malaysia, endorsed by NCOT. We have to create the syllabus, 3-yearly review, keep it updated, and everybody gets the syllabus for free. So there must be a system to dissipate basic entry-level trauma training. Yeah? National trauma policy. So this is something we've been working quite hard upon, and we coined this concept, the Malaysian trauma chain of survival. What it means here is everybody is important in trauma. Nobody is not important. You cannot say, oh, only general surgeon is important. No. You cannot say trauma physician is important. No. Rehab is equally important. ICU equally important. Everybody, the pre-hospital care paramedic is equally important. Everybody needs to do the job right. And the chain is only as strong as the weakest link. So whenever there's a link which is weak, it's the entire chain's responsibility to make sure that link is strengthened. Because everybody else's strength is dependent. The concept, Malaysian trauma chain of survival. So this we release in the national trauma policy, hopefully released, accepted, hopefully will be released soon, yeah, by KKM. No more sending to just the nearest hospital. Send the patient to the nearest most appropriate hospital. Sebab kalau tak, to send from that center to that center takes you another 4 hours, you know. So spend the extra 10-15 minutes. If it's safe, send it to the most appropriate hospital. Level of a sentence 1 to 4, 1 to 5, based on the abilities of your center. Trauma center level 1, level 2, level 3. So these are initiatives from us, the trauma patient group, put up in national trauma policy. Yeah? You must have governance, ministerial level, state level, hospital level, clinical governance, and TQIP, total quality improvement programs. Without data, we are blind. This is the Malaysian Trauma Registry. Hospital Kuala Lumpur is one of the main centers, a contributor to the MTR among 20 hospitals in the country. So we just launched this at the end of 2021, and this is the way forward. So this is how we will know what is our epidemiological outcomes of our trauma patients in our country. So in the next 5 years, we'll have mature data to pave the way subsequently. So moving towards digitalization and data-driven outcomes. So future, I ask you this question, what's going to happen in the next 15 to 20 years? Number 1, I hope I will continue to remain young. Number 2, I like it. Infrastructure-wise, damage control resuscitation suite, not only can we do now laparotomies in our DCR suite, not only we can do resuscitation, of course, but we can hopefully also do advanced interventional radiology procedures. Yeah. So it's hybriding services. No more the patient go to the team. The team comes to the patient. The team can change. Yeah. In all hospitals, at least tertiary centers. Moving towards minimally invasive resuscitation. Who wants a laparotomy anymore? You don't want surgery, you want scope, right? In trauma, you want laparotomy or you want IR. So using minimally invasive techniques, yeah, Reboa, viscoelastic assays, ECMO, yeah, and trauma patient-led or consultant-led services in future. Having access to education for free. Nak promote sikit lah, next one is 30 hari bulan ni. So we have every month we do a trauma series CME, yeah. So we bring our trauma physicians with other specialties and combine. And Datuk will be involved in one of these two. Yeah? So we do this for free, and we get quite a large audience, and we are happy. And I think the feedback has been quite helpful for people. So across the country and even other countries, from Indonesia and Philippines and all that, they join in. So access to education is important for sustainability and growth. Free education. System-wise, information technology and seamless data transfer. There is no way. You like IT, you don't like IT. IT is the way forward in medicine. The faster we absorb that fact and get ourselves in line with digitalization, the faster and better we are going to be more competitive in the next 15 years compared to our neighboring countries. And it all starts with us, with you, with me. Yeah, that is the way forward. What do you mean by IT? Digitalization, record data, analysis in every level of your own work. Yeah, storage. Artificial intelligence in video imaging interpretation. It's going to move towards AI. Even our ultrasound machines now come with AI. Your X-rays will be AI. Your CT scans will be artificially intelligently reported before the radiologist gives you the report. It cuts time, improves accuracy. Humans are only involved for the medical legal purpose of it. Yeah, the interpretation. The signing off is only medical legal. Everything is going to move this way. We should start this in the ED itself fast. It saves us a lot of time, reduces error. Yeah. Patient trauma registry, data-driven survival prediction model. We need to predict our future. How do we do that? By analyzing the data of the past. We need to know this patient, what's the odds of you dying? 30%, 60%, we need to know that. That is the only way we can absorb resources accordingly to those who are in the most need. Digital end-to-end out of hospital trauma notification and team system activation. There's no more going to be surprises in trauma. Yeah, we'll know everything that's coming in. We'll decide everything that's going. That way, the entire system is in a controlled environment. I leave you with this video. Ada volume. So this is just a little bit of the trauma suite services. Yeah? Pre-hospital notification. Call comes in. PCR alert sent out to the entire team. Case comes in. Team is prepared. Trauma team on the board for the day. Trauma reception preparation. Patient comes in. At the drop zone. Initial assessment done. Admits or whatever we are going to use. Yeah. The structure will mirror the service. Interventions done rapidly, no delay. From time zero. The process of providing the care is done in a safe environment, yeah, because your infrastructure supports it. Clean. Hemorrhage is controlled immediately, no delay. Yeah? Hemorrhage kills, yeah. Hemorrhage kills. Matter of fact, it kills faster than airway in major trauma. Huh? So even in the new guidelines, is C in the little bracket first before ABC. You realize there is control of exsanguinating hemorrhage first, then airway breathing circulations. So the patient is managed, yeah. Blood cells involved, so everything is going to be fast. Time is the essence, yeah. Any delay leads to morbidity and mortality. It just equates that, and we've seen that day to day, yeah. So this is how the ultrasound machine system works. The ultrasound doesn't come to the patient. The ultrasound is waiting for the patient. There's no delay in that, yeah. Delaying the fast scan delays the identification of hemorrhage. Primary X-rays, we still don't have things coming from the roof yet. We do the next best we have. Yeah? The X-ray comes to the patient. the X-ray comes out immediately onto the screen in the DCR suite. So everybody has a role to play. So that way, despite irregularities and inadequate numbers, the efficiency maintains. Everybody is trained. Now you have next, you're going for a PET scan, for example. Yeah. So move, transfer, the X-rays are seen, the primary X-rays. And you go to a CT. CT locations have to be nearby. Then the team itself is in the CT interpreting, not necessarily just the radiologist having to wait for the report. Yeah? We interpret images ourselves while waiting for official report. Here is where I talk about artificial intelligence in radio imaging interpretations. Yeah? This is where it will help us even more. Interpretation done comes down to step down. Yeah? DCR step down, and then subsequently goes wherever they need to go. Ladies and gentlemen, thank you very much for this opportunity. To be here, and Dr. Ibrahim and the team, well done for your trauma week. Thank you so much.
And thank you, Dr. Jahan, for that excellent presentation. So now I would like to invite again Professor Datuk Sri Abu Hassan Shadi to give out a token of appreciation. It's not iPhone. Okay, so sekarang kita ke ceramah yang terakhir. Ceramah yang terakhir tak lain dan tak bukan is Profesor Datuk Sri Abu Hassan Asyari Abdullah. Yang gambar kat sana tu. Walaupun dia tak ada kat sini, dia sentiasa memerhati. So mantan Ketua Jabatan Kecemasan dan Trauma Hospital Kuala Lumpur dan juga former Head of Service Emergency Medicine Malaysia. So also father of modern emergency medicine Malaysia. So siapa yang tak kenal lah. Jadi beliau berkhidmat di sini selama lebih 25 tahun tu, kalau tak salah saya, 25 tahun dan telah bersara pada tahun 2017. So without any further ado, also ialah mentor kepada ramai pakar-pakar di sini. Also father to all the young ladies, right? Okay. So without any further ado, I would like to invite Professor Datuk Sri Abu Hassan Asyari to deliver the last talk entitled Damage Control Resuscitation. Okay.
Very good morning, everyone. First and foremost, I'd like to say thank you to Ibrahim for bringing me here last minute and asked me to give a lecture of my choice. And I must congratulate him for a very interesting, what we call a discussion or sharing of knowledge. And also we heard Sajahan, who have given a lecture. And just to tell you that he was giving a lecture on my behalf, and most of the things that he wrote there, it came from me. However, he didn't say it properly. I was like, okay, fine. But you know, just to tell you all that, this trauma surgeon, perangai lebih kurang sama lah. I didn't train them to be so naughty, but he became naughtier than me. So inheritance is there. But anyway, look at them. Pakai smart lah sikit. Dan dia pakai dia punya Hermes. Kalau pegang tu yang tiruan punya. Anyway, they emulate me, and I'm so proud of them. And I created them. And unfortunately, you notice that they learn a lot of the nonsense rather than the knowledge. I must say to you, I'm so pleased today to see he translated my philosophy, which I started a long time ago. Let me introduce myself just a bit lah. Actually, I am the first trauma surgeon in this country. I was trained in the United Kingdom, and I am not an emergency physician per se. I'm actually a fellow of Royal College of Surgeons, Edinburgh, and I did my 6-year training in the UK for trauma and trauma surgery. And that's why I'm so happy that it's already translated in Sungai Buloh. And just to tell you that Sungai Buloh, Jabatan Kecamatan was my design. And that actually the trauma suite was finally being used in the manner where it should be done. And congratulations, Sajahan. And when I designed Sungai Buloh Hospital, there were about 4 trauma theaters, and none of it was used properly. But this is why I say I have a sweet taste in my tongue to see that some of those things that have been translated into reality, like he said before, yeah, we should predict the future. But you see, that's why he only learned half of the philosophy. The philosophy sounds like this. You predicting the future is not enough. Creating the future is the order of the day. So next time you just say predicting is not enough, creating. So we have to create the future. Okay. Now another quotation that he used, that's mine. Actually, the quotation sounds like this: structure mirrors process. Structure facilitates care. That's my quotation when I designed emergency department for the whole country. But having said that, if you look at the other thing that he quoted, my quotation was Gaussian ergonomics. Huh? Now, Gaussian ergonomics is a very important thing that, thank God, one of the things that have been done by Sajahan is translating that into the study that I did in Edinburgh, and that study is called horizontal task distribution. Nanti kita talk about that. But he has given a lot of the component of my lecture, but here now I'm going to give you all the scientific aspect of it. And this one can be a bit boring, tetapi bear with me, because you know why? What he has done was very good, but you must understand why it should be done. Huh? So that's why this lecture entitled Damage Control Resuscitation is actually not one lecture. All of them was involved with me creating the first course, what we call damage control resuscitation course, which was three days. Huh? And where most of these things that he said was done during the course, and you all should apply to have this course, and we should do the course again. Because this course, next slide, please. This course is actually, this course is the concept of, this is important concept. Let me explain to you the title. Now, we talk about visionary extrapolation. What does that mean? You see, there are a lot of creativity in this. When you want to do damage control, you have to think about what to do. The classic one, we saw there was the use of the hemostatic powder. I tell you what happened. Hemostatic powder has got 2 types. One liberates heat. The other one, actually, the later one is actually the hemostatic powder that actually would not liberate heat. I tell you a story. Yeah? Sajahan did it very well. He put the hemostatic powder into a gauze. And the gauze is shaped exactly like the size of the wound. So when you press on it, it's called focus pressure. Okay, and that focus pressure is the one that plus the hemostatic powder, it causes hemostasis. There was a surgeon who was actually trained by me here also, but he's naughtier than Sajahan. This trauma surgeon, this is not trauma, he's a neurosurgeon. Same thing, he used the hemostatic powder, but he used the one that's liberating heat. You know what he did? He poured into the brain that he was operating on. So what happened to the brain? The brain got cooked. Huh? So he was sued. Huh? So this is why when we talk visionary extrapolation, we have everything there with you, but how you use it is using what I term as the overriding wisdom. Huh? So you have tools and gadgets, but using it in the right way is the concept of visionary extrapolation. Okay. What is the philosophy that what has been said by Sajahan? Is actually we are first and foremost extending our boundaries. Those days correctly been mentioned by Sajahan. When I came back from UK in 1992, some of you are not born yet. Right? The emergency department is just a place like the post office, you said. Now we just try to diagnose, which we will never be able to. We don't have enough equipment for that. And we send. This is sending to somewhere else. Then we develop triage and so on and so forth. After we develop triage, we develop what we call the colored dedicated zone, and we develop all the concept of resuscitation and everything. Now, when we extend the boundaries, it means that we are going into intervention. Not that we are making the orthopedic surgeon irrelevant, not that we are making all the surgeons irrelevant, but they become irrelevant if they come late. See, this is why what Sajahan is doing and what some people are doing here, even in the medical field also, we do thrombolytic therapy. We are now into intervention just when it needed most. So he didn't mention this. I created a song. This one is called Just When You Need Most. Now, the truth of the matter is, this is what you mean by the first one. Extending frontiers and widening boundaries for prolific intervention. Now, number two, this is what we are now having this objective. The objective is time is equivalent to myocardium, is going then equivalent to life. Now, if the disease process or the effect, the metabolic response to the injury is amplified or become worse by the delay, then we have the cascading effect of the metabolic response. I will talk about this in a while to justify what all Sajahan is doing and many others. We want to actually terminate the metabolic response, because as the metabolic response becomes more amplified, the body will become very challenged by so many things. In fact, in some ways, the physiologic, this is interesting word you must remember, what they call it, physiologic exhaustion. Now, physiology is in our body become exhausted to try and stop the bleeding and this and that and the other, in so much so that the body will give up. So, it will then cause what we call the multiple organ failure. So this is the main thing, that reduce the cascading effect of metabolic response to injury, prevent physiologic exhaustion, and prevent multiple organ failure. All right. Now this is why we want to invite you to think this way. You must get the competency. So go to Jahan, go to everywhere. Remember Jahan saying that you are to perform at your level the best. So we don't expect you to like it, but you expect you to be able to get the equipment as soon as possible, for example, for nurses and for PPP. Now we actually emphasize on this. We have to develop your competence to a certain level that when you respond, you can do what you are supposed to do. And if Sajahan is not around, or Ibrahim is not around, or Zaman is not around, you can be the team leader. At the end of the day, the competency-based education is no more academic. It's focused on skill and competency. And that's what we are now promoting. And if I were you, you must tell yourself, at certain time when you spend in the emergency department, you must ask, what competency you have? If you don't have competency, don't waste time. Because you know why right now, whatever it is, you see all the successful multi-billionaires, some of them are not academically trained. Steve Jobs, all these people, Bill Gates, Lim Gotong, they are not academic, but they are skilled in business important. So if I were you, yes, you already got the certificate. The next phase is get the competency. Now, what we are trying to do is that to go higher in our clinical echelon. Now, if you are PPP, don't limit yourself to PPP in scope. You have to extend higher. And if you're a nurse in emergency department, those days when I come back, the nurse take the ward out and they present. And those days, actually, we expect the nurse and the PPP to be able to initiate resuscitation. And you should do that. So this is what to put you all higher in the clinical capacity and capability. Of course, later on, we talk about just-in-time skill. That's what you see just now, all that bleeding, being arrested, and so on. That's what is needed at that time. And then, of course, what we call razor-sharp decision-making. Now, most of us, if you, in trauma, it is so clear. Okay? You must understand the biomechanism of injury, translated that the predictive, what we call trauma prediction. Then we can also what we call prognosticative prediction. And henceforth, we have to come up with a very good decision making and also prolific intervention. What we saw in the video, just now, a lot of it is a very prolific intervention just in time. Now, this is also important. When the patient arrives in emergency department, we don't muck around anymore. Early, high level, early definitive detection must be instituted. So, you see, when you are trained up there, what we call the bedside clinician, I'm not saying that thing about them, but you are trained to class the patient, to examine the patient, send the blood for investigation, wait for diagnosis, and treat. Betul? That is bedside clinician. Frontline clinician, one look, come up with a working diagnosis, zoom into it. So, early, definitive, and high-level intervention. What you see just now is exactly that. By the time the patient comes from the triage counter, straight to the theater or the suite, intervention be done within 10 minutes. Okay, next. Now, in actual fact, the history of damage control resuscitation is from these people. Now we talk about SWAT and they do what we call all the phases of, they do simple things like packing, liver injury, and most of these things been done for the purpose of preventing the the amplification of metabolic response. Okay. Now, this modern damage control resuscitation is now have a very wide scope. It includes medical and trauma, but today we are focusing on trauma. And a lot of things that have been said by Sajan is really component of this, the modern damage control resuscitation principle. Next, please. Okay, I know you saw this before. I'm not going to repeat what has been said because we need to go to something more specific. We heard just now early initiation of blood product transfusion. Okay, we prevent crystallite fluid administration, permissive hypotension. I'll talk to you a bit about permissive hypotension. And of course, immediate hemorrhage control. Next week. Okay, this is what we now promoting because first look, surgery is if is required, we won't believe them. Now, surgery doesn't mean operation itself, like ligation is also a form of surgical intervention. Now, abbreviating operative intervention in the shortest duration because the longer you put patient in anesthesia, there are a lot of other negative effects. Fluid therapy is very crucial, but not about volume. It's about titration. Coagulation management to prevent the IVC, or what we call consumptive coagulopathy. Always bear in mind, most of the time, most of the patients die because of this consumptive coagulopathy, where patients start bleeding and we cannot control the bleeding. Now, physiological balance, preventing physiologic exhaustion. I said that before, and I'm repeating myself. And of course, many more. Now, second look surgery is exactly what Fajran did. For just now is for the wound or for the bleeding there or for the thoracic surgeon. Most of the time, liver injury. And I've done many times. Open abdomen, pack, and close. Send patient to ICU, and the surgeon can do it at the best time. All right, so next please. So I'm not going to deal with that too much because the theory is aplenty to justify. Okay, most importantly, if you look at it, some of the resuscitation procedure cause more damage if it's not careful, especially fluid resuscitation. Because why? Later on, I will tell you this, that in trauma response, one of the things that will happen is called capillary permeability. The more fluid you put in the patient, the more fluid will go out to the third space. And that will cause ARDS and so on and so forth. Okay, next please. Now we know, and I think all of you are quite familiar with it. Trimodal distribution of pattern of trauma death. Okay. Now, when the patient comes along, in the first few minutes, if the patient dies, that means the trauma is very severe. Now, like you talk about Princess Diana, when she died at the site, and they were saying that why they waste so much time, they should take her to theater immediately, blah, 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 blah. Whatever the case may be. Nowadays, yeah, we are still trying to treat the patient that belongs to the second peak of trauma death. But of course, we still can lose patient after a few weeks when the patient in ICU. But the most modern trauma system should be able to manage the first peak. And this is what we saw. Some of the things that Sharia did was actually encroaching into this. Like that young boy, 14-year-old beside the motorcycle. Because if in many other hospitals, if they are brought to a places where there's no intervention, the patient will die. Because that kind of injury, about 80-90% in most of the facility, patient will die. But if you have a guy like Fajahan and the team that come and intervene, then even this first bit we can try to. Yeah, got it? So that's what we are now. Now this one is no brainer. It should come in many departments. Kalau dia patient will die within a few hours, we should be able to treat it. Okay. Okay. Now in the first bit, you know that all this laceration in the brain, brainstem injury, spinal cord injury, all these are very severe. But some of these things are now beautiful. Now just now we saw a lot of heart and great vessel laceration have been ligated in good time, or for that matter, have been managed properly. Okay, next week. So this is what we've been talking about anyway. So we should be able to manage patients that have got injury that can die within a few hours. Now this is why when Fajahan mentioned about trauma system and so on and so forth, and now he's talking about digitalization, of which now I'm also doing that. Digitalization of emergency department, of ambulances, and so on and so forth. Anyway, next please. So the second thing we talk about, I know this one you learned a lot about pneumothorax, regularization, pelvic fracture, just now, and so on. This we must be able to treat. Kalau emergency department not able to handle the second peak, that means we are not good enough. Huh? We check the second peak, that is our focus. Okay, next please. All right, okay. Now sepsis, organ failure, when the patient goes into ICU, it's not really our responsibility. But what happened to the patient in the ICU, whether the patient responds or not, is actually our first intervention, which what he mentioned about total quality management. What do you mean by total quality management? It means that at every phase of the intervention, it has to be done at very, very high quality. So we see just now, if we are able to handle trauma quickly in good time, that's considered very high quality. So it may, in fact, prevent this. Right? Okay, next please. Now, I will not be able to go into the specific because this is the whole, what we call physiological principle of damage control resuscitation. You see, we have the shock phase, resuscitation phase, is what we know already. But if you look at this, catabolic phenomena and self-destructive, we have to prevent this. You know, this is why later on I will explain some points on this one. Excessive inflammation, increased energy required, protein loss, carbohydrate, whatever, you know. As an example, I give you. In trauma situation, there is this situation called insulin resistance. Now, what will be the thing that causes insulin resistance? It will be adrenaline or free fatty acids. All this will be created as byproduct of our response. What do you mean by insulin resistance? It means that we cannot absorb carbohydrate. And we cannot absorb carbohydrate, we cannot, no calorie, and all our protein and our fat will be what we call the mobilized, or otherwise the store will be damaged. Okay, let's move on. So I mentioned to you that catabolic counter-regulatory hormone will be produced. Amplification of catabolic effect. Shunting to the vital organ, and we can get inner shutdown because not enough blood to the kidney. Ischemia due to vasoconstriction. There are a lot of people who undergoing trauma can get ischemia to the intestine. You know? Okay, insulin resistant, inflammatory response. So many of these things, you see, elevation of free fatty acid due to lipolysis can cause insulin resistance. Now, this is why, if you don't realize it, the longer delay in your intervention, the amplification causes a lot of problems. So we have to intervene that. All right, so next please. Now, this is aspect of shunting, rerouting, redirect blood flow. What is good, because in the initial phase, we need the brain, the heart, the kidney, blood flow must be maintained. But if it continues too long, then we talk about this compensating mechanism will have a detrimental effect. Okay. I know this part of the lecture is very boring, but I just want to tell you that what he is doing, I've got this reason why he did it. Okay, next please. Now, I mentioned to you many times, sympathetic response plus vasoconstriction. Very simple arithmetic. The longer the vasoconstriction, the worse it becomes. Okay? Okay, this is what I'm just saying to you just now. Decrease capillary pressure and it will cause increased permeability of capillary. Now, this is the one that will create fluid in the lung and so on and so forth. Whatever fluid you put in, that's how if you give, we have a balance of colloid and crystalloid. You know colloid. Colloid is the molecular weight particle within it is about more than 30,000. Now what happened to this particle that if it goes to the lung? It will pull the water out and we will not be able to sustain intravascular volume. So we want to prevent this as soon as possible. All right, so exactly what we said just now. There are a lot more theory behind it, but I'm not going to go into so much detail. That's good. Okay. Again, capillary permeability. Next, please. Okay. The neuroendocrine response to hemorrhage is the effect that will happen to the brain. That a lot of this in the neurotrauma cause hypoxia because of the concept of it probably. I will not be able to talk to you about this one, but it is called the Monroe-Kelly doctrine, the rigid box. Anyway, never mind about that. We can remember that there will be a big issue on this one. Next, please. Okay, next, please. Next. Okay, you can see adrenaline will affect hepatic, skeletal, and then mobilizing fatty acids. All this will be cascading in a big way. Actually, it happens within 1 or 2 hours. Okay, okay. I'm not going to be able to talk about that in detail, but just the impact upon it that all this is happening in the body within 1 or 2 hours. Okay. The secretions of hormone from the pituitary gland is the one that is responsible. Actually, they are being delivered to the system to manage the system for a while. But when you talk about physiologic exhaustion, we report too much into the system to cause problems. Okay, thyroxine. Okay, just this one. Okay, fine. Next, please. Now, this is what we are now having to prevent. The lethal cascade of the event: acidosis, hypothermia, coagulopathy. So we have to prevent this simply because when there are a lot of anaerobic metabolism, acidosis will happen, and then the body temperature become low, and it also reflects in consumptive coagulopathy. Okay, please remember this if you are going for exam. If somebody said what happened in metabolic response to injury, you say the cascading effect. Okay, this is next. So again, all these are what we call the scientific background. Okay, now remember what Sajahan mentioned about the Gaussian economics. So I invented this. What he said and what he translated that into the suite is exactly what I did. And this was done when I was trained in Edinburgh. When I was trained in Edinburgh, me and Professor David Skipman took a video of resuscitation process. What Sajahan said is exactly what we saw. People are carrying sharks from one place to another, running here and there, and what we call a lot of spermatic movement. What do you mean by spermatic movement? Out of this volume of sperm, that if there only one will create pregnancy. Betul tak betul? Do you know about that? So a lot of them are moving like Sajahan. Those people, they're moving just like that. You know what they're doing? So when we saw the video, we were thinking, oh, I mean, so many movement, but only the team leader is doing some work. They are running here, running there. Precisely why we therefore create this thing called the horizontal task distribution. That means place them in a position where they can reach for the equipment within their confine. That's what we call golf swing economics. Golf swing means I've been trying to train him to play golf. Until now, there's a thing that they never inherited from me. Now, what do you mean by golf swing economics? That your body, your waist don't move, you just move your hand. Okay, so let's have a look at it. So I created this pendant and panel, like this one. So that's the thing that the first department that used this one is emergency with HKL, which I actually invented together with a guy called Agnes Nielsen from Sweden. Then from then on, and the CGI department, Operation Theater, everywhere they use this. Next, please. All right, so what do you mean by permissive hypotension? He mentioned it a bit just now. This can only be done in a facility where you have a lot of support and where the intervention can be done early. You cannot manipulate the hypotension if you are not able to support it. We are allowing the blood pressure mid-arterial pressure to be as low as 40 to 50, which means that systolic can be as low as 90, 80, and diastolic is about 40. So we want to keep the patient dry. The reason is because there's a guy later on, if you want to Google, you Google this guy called Kenneth Mattox. Kenneth Mattox is a cardiothoracic trauma surgeon in Houston. In fact, I brought him here. I came and presented paper here. This is the guy who started. This is the guy who started permissive hypotension. But he's also the one who said that the biggest hope of mankind is mouth-to-mouth resuscitation. Anyway, he never believed in that anyway. So he said that is the biggest hope of mankind. And an interesting guy. You know, this Kenneth Mattox, we brought him to Indonesia. Can you imagine in his keynote, he was reading the Quranic version. That guy is really dynamic. He quote Quranic version. He said, this is resuscitation or resuscitation. Wow, very interesting. And he quoted that statement. That's from Surah Al-Ma'idah. For every one life you save, is as though you saved the whole mankind. And for every one death you create, as though you kill the whole mankind. This is very interesting because much deeper than that, the meaning, but I don't have time to talk about it. But anyway, permissive hypotension, Kenneth Mattox actually the one that promoted. But the promise is, if only when you can manage the intervention as soon as possible. If not, if those of you are going for master student, if they ask you this question, when will you be able to apply permissive hypotension, you must say that in a facility that you can have intervention done in good time. If you don't have the facility, you do permissive hypotension, the patient will suffer. Yeah? Okay. Now, indicated only when damage control resuscitation intervention is within 3 hours. Got it? Why? Because we are playing with the pressure to maintain. We're going to make the patient a bit dry to prevent capillary permeability. Remember what I said? That when you give too much fluid, it goes into the third spaces. So we maintain kind of a bit dry so that we can prevent the cascading effect. Okay, next please. Okay, so now the component, yeah, damage control resuscitation. We're going to talk about the pre-hospital care damage control. We talk about vascular damage control, and later on we quickly try and look at some of those damage control in the various fields. Okay, next please. Okay, we talk about vessel ligation. Well, classic, we saw just now. One using tourniquet, the other one using hemostatic powder. And there are a few other components that you almost get familiar with this. Because somebody's asked you all later, what are the various methods of preventing hemorrhage? Well, you must be able to start up. That you can use as soon as possible. Ligation is still there, hemostatic powder is there, compression, and so many. And of course, in a much more sophisticated environment, you can use balloon catheter tamponade, direct pressure, and tourniquet. Let's have a look at some of this. Okay. This was what we did. I think you were there. This was an explosion at the MRT. Yeah? The Bangladesh worker, about 3 of them. 1 of them died on the spot, and 2 of them came to the department. And there were traumatic amputation of the glass. So we were applying all the principles of damage control. Very interesting. And we were able to manage it well. Because quite quickly, we managed to ligate, we put powder, we do tourniquet, and the whole works. Okay. You know, you can see applying tourniquet, and we're doing the ligation. Okay, next. That's what we do. So I was there together with a few others, and actually we managed to arrest the people. So I don't have video lah. Ini very dramatic ya. Jadi memang macam, you know, he's from Pakistan, so he a bit of Hindi movie lah. A bit of Hindi movie. I tell you the story, you know. This naughty boy, the father came to me. The father is my good friend. hey, brother, take care of my son. I cannot take care of his business. I said, make him a man. I said, oh, shake it. And then, very interesting person. The father is a very interesting person. The father is a dental specialist. Very interesting. That's what he said. My very good friend. We all sing together, jump together, and so on. But my effort to create him a man, oh God, you know. I said, don't chase woman, chase knowledge. Huh? Okay, boss. Now, I just want to mention two things that I said just now. Intervention must be done, but the wisdom must be there. You cannot just do it blindly. Because tourniquet itself causes problem. You don't simply just put tourniquet because you know that it will be an Arabic metabolism. Right? When you release the tourniquet, there will be problem. Okay, we'll talk about that in a while. Okay. So we use hemostatic powder, but how to use? Again, put into a small ball and then do compression. And then when you bandage with a small, many ball like so with a focus pressure. Understand? Not just you pour the powder, it works, but then it may be washed away by the bleed and so on. Okay. So we use Silox. Silox is no temperature. Okay. So wound like that. What do we do? This is what we chest wound. Okay. Next. Okay. So many more situations. I'm not going to be able to tell the detail. Right? Okay. So in terms of the other one that you all must understand in terms of damage control, this is very interesting. For those of you saw just now one crush. But for those of you like Azamani always been doing this, responding to disaster. When you respond to disaster, we send some of you like Rao went to Philippines, and you all went to Philippines. Tacloban, huh? When you go and do in earthquake, a lot of them get buried. Huh? Now remember, that's a very interesting scenario. This is what we call the crush syndrome. Huh? Now, crush syndrome can be lower extremities, can be upper extremities, can be the trunk. Because if you are buried, the trunk will undergo. Now, crush syndrome is very common in disaster with collapsed building. Of course, the motor vehicle entrapment, crash vehicle, and then the chest is being compressed. Motor vehicle accident and so on. Let's see some our experience. Do you know that those days that one time all these stupid students do this crash game, chess crash game? You know? Have you? We don't know. You know what happened? Those boys, they go and cari the kawan, they tekan the chest, and then after that the kawan pensan keluar and then hidup balik. That also become a game. How silly, yeah. Now just imagine if you press the chest for a long time, all this response will actually can cause death. Now, why I say so? Many of the motor vehicle accidents, especially entrapped in the vehicle, when they are actually pinned into the dashboard, when you release, you know what happened? All the anaerobic metabolism that have been happening during the compress, they release all the toxins. And that's why I'm going to go to the next topic next week. This is an example. This is the. This one is a terrible accident at Agro. I think some of you may remember this. It caused massive jam between a bus, and we were. I mean, this is an example of crash syndrome. But the intervention was done quickly, and some of them can be saved. If you all remember, the Island Tower, some of you may not be born yet. Huh? That was my first experience. In 1993, my first experience in managing disaster in this country was at that time I was in Langkawi for the Lima Langkawi. So I came back and there was a Japanese lady who had been crushed pelvic. Yeah? That's when I got the idea to invent this pelvic clamp. Huh? Because this lady was actually bleeding profusely, and we actually took her to theater and operated, and we saw the pelvis was like bits and pieces. Huh? Then I realized, that actually the lady passed away, but we actually managed to control the bleed, and it was delayed. That time I realized, therefore, The death is actually basically because bleeding from the bits and pieces of the wound and the bone. So here now, this is a crush syndrome, crush injury. There's a bit two different things. Crush injury is managing those pelvis, those limbs, what you saw just now. But crush syndrome is the effect of the crush situation. They are quite two different things. If you talk crush injury, you're talking about the specific part of the body. When you talk about crush syndrome, you're talking about the response because of the crush situation. Okay, let's have a look at the next slide. Okay, so the pathophysiology of crush syndrome is covered by Eric Firewalters, a British physician. It is described as the reperfusion injury appears after the release of the crushing pressure. Okay, so this is, be careful. When the crush pressure is released, then all the metabolic product from the anaerobic metabolism actually will be circulated, and they are very toxic to the system. The mechanism is believed to be the release into the vascular system and the bloodstream of a muscle breakdown product due to cellular destruction and increase in capillary permeability. All right. Now, rhabdomyolysis is an example, okay, which is damage due to ischemia and anaerobic metabolism. So we have this thing called myoglobin, which is everywhere. So just remember this when you go to disaster site and you are managing any of this entrapment. Always remember, what do we do when you see somebody strapped in a car? What do we do? Huh? This is something that you must know. I could tell you, very simple. When anybody is trapped in the car, what you do, you set two large port cannula, put fluid. Now remember, he said, my quotation, dilution is the solution to pollution. Okay, so you flush in fluid first. When the compression is reduced, when the compression is released, all these toxins will come out, you dilute it immediately. Okay, one. Secondly, the use of bicarb. Now we can debate on that later. And the use of magnesium. Anyway, to cut the long story short, you please recognize the part about when you see somebody strapped in a car, crashed car, always remember crash syndrome. Okay, next please. Okay. It affects the kidney, nephrotoxic cardiovascular system. All these myoglobin have got a lot of negative effects everywhere. Sudden decompensation after aspiration is called the smiling death. So let's talk about this smiling death. This smiling death came from a situation where it happened in Chengdu. Chengdu, there was an earthquake. So this man was actually crushed, was actually caught in a rubble of the collapse, but his face, his body, three-quarter bodies. So he can talk. So people give him handphone, he called his wife, I'm okay, everything. So when they extricate him out, he was smiling. Admit to the word, he died. So they come up with this terminology called smiling death. The smiling death is basically all this, the neurotoxic situation, then also all this situation of toxicity to the heart and so on. Okay. Okay. Now, on-site management of crush syndrome to avoid sudden decompensation, the smiling death. Okay, I know I'm a bit of time or something. Even if I'm over time, I don't care, you know what I mean? You think they dare to ask me to stop? No, wait. All right, so suddenly we actually have to debate on this one. I mean, for all intents and purposes, this is quite common. Crash car everywhere, but we never understand this entity. Then the question of you worry about giving so much weight. You said that the capillary permeability, but then what about crash syndrome? So the concept is, while the patient is being crushed under pressure, put the foot, bring the patient up, then we titrate. All right, so they say in the UK system, the risk of crash syndrome current recommendation is to lay first responder not to release the victim of the crash injury who have been trapped for more than 15 minutes. All right. The application of tourniquet at the proximal part of the crash syndrome is recommended. That's UK system. Okay. So you don't release the compression, apply tourniquet, and fluid overloading. Okay. And that's what we call It doesn't matter what fluid, as long as to me, any fluid we can do. And slow release of compression pressure and if the pressure is released on site, okay, later on we do fluid restriction and so on and so forth. Next, please. Okay, in the US system, if it, main-main, turun bakar, okay. In US, the crash syndrome is with more than 4 hours. The risk of crash syndrome is very high. Of course, US system recommend first responder to low fluid. Again, same thing, yeah. 2 liters of IV bolus saline and so on and so forth. Apply to Nikkei. And there are many more. The debate continues. For intensive process, loading, dilution is the solution to friction still. Okay, next please. Okay, the main objective to prevent hypotension, renal failure. Kita bulan puasa kena sabar. Boleh? Before this. Okay. To prevent hypotension, renal failure, acidosis, hypokalemia, and so on. Treat all the wound, apply ice, reduce of friction, blah, blah, blah. This one is in a situation where you have the crash syndrome that you, okay, remember. Intravenous sodium bicarbonate to keep urine pH at the level. This one is the challenge. Some of them say yes, some of them say no. But in any case, just think about it. I cannot continue discussing about this because the time is not permitting. But just to mention that there are all this menu or process to handle crash syndrome. Right? We won't deal with the details. Okay. Now this was my invention, what I call pelvic. Now you notice that actually what Sajahan did now, very interesting. This is a kind of like based on the same principle. What's the principle? The principle is Professor Ismail Saibun actually invented this pelvic band binder. So I and him, we do. That's one thing that I don't agree on. Pelvic binder means you apply the pressure anteriorly, whereas where is the bleeding from in pelvis? Is what we call the posterior osseous complex. I think it's still okay as long as you have something. You know, Ibrahim, when he present one day with me, he thought I was not there, so he present pelvic binder. So you he did not present my invention because he worried that he's become unpopular. You know? But actually, popularity is not important. Important the justification. You notice that when he invented, now going to invent this thing called what's it called? Yeah. The basis is the pressure must be posteriorly. Understand? Because we are to prevent the mobility of the most vascular part of the pelvis. The most vascular part of it is the sacroiliac joint, where there are a lot of vessels around there. This is why the principle of my invention is using the compression plate to compress and what we call the external tympana. External tympana. So we reduce the pelvic volume, we prevent the movement of the pelvis, and more importantly, the pressure is posteriorly. Okay. This is the invention. It's called Nina pelvic immobilizer, and I invented it in 1990 actually. But no, a bit later, but around thereabout. Yeah. Okay. Anyway. So, unstable displaced fracture pelvis with this type B and C grade. I don't think you need to know about that, but more important, dislocation or attachment of the pelvic sacroiliac joint. And of course, crash injury with multiple displacement. Okay, since we will not be able to diagnose it, and Sajani is correct that you cannot do pelvic spring. So therefore, we put it in all the ambulance. If you suspect there is such, whether it's soft tissue injury or bony injury, just apply anyway. Then bring to the department, and then we'll do the X-ray accordingly. Not like as though we can see this at the site. No, I will just show you to make you understand the type of fracture. But on site, it's all based on biomechanism of injury. If somebody been run over by a car at the abdomen side, there's no harm. Okay. I won't be able to talk to you about the indication, but I want to mention to you, okay, this is quite therapeutic. Okay, so this is the method of doing it. Later on, maybe we can have a look at it and play around with it. I'm now in the process of inventing this using fiberglass. I'm just, in fact, working with a new production line to create something lighter weight. Actually, in one of my company, I market it under cryptocurrency. Yeah? If you Google Maxi, I mean, this is now market analytics 2.6. Okay, this is the application. Okay, like this example, you see the separation of the diaster system or the Curie synthesis, and also at the back, you can see. So we apply the pelvic flare, you see that it has become closed. But it's not about reducing the fracture. It's about external temporal. Okay, prevent life threatening in the hemorrhage by early rigid stabilization and provide early rigid stabilization during transportation of the patient and also pain reduction. Okay, it can be applied on site by paramedic because it is not what we call intrusive. It's just like polar, just like I said just now, we apply polar and we apply immobilizer for the we reduce excessive use of physics, and of course, it becomes a very important prevention for systemic complication. What's the most important systemic complication for pelvic injury? Fat embolism and also ARDS. All right, so next please. Okay. Okay, this one we said already just now. Now, decompression can also be by suturing. Can be also by suturing or can be released. This is an example where we did decompression. We open up and we stitch at the gap so that the pressure within it will be able to be accommodated. So this is quite important. I think we all know about aspiratomy. But remember, in some of these crush injury of the muscle, when the pressure within the muscle increase because of the edema, then in fact those days we used to measure the pressure of the cup, and then we do a release, what we call this, release the pressure wound, and then we stitch it at a gap. Okay. So just come back to the original philosophy. If I can give a short summary. A mesh control resuscitation is high-level intervention, which has been done for the purpose of preventing the negative effect of metabolic response. And it is very important, but not many people are familiar with it. And unfortunately, when you're not familiar with it, you're waiting for the relevant department to come. But they are trained to diagnose first and treat later. Whereas we are not diagnostic chaser. We identify what patient needs and just give the patient what they need at the good time. Now, that's why you need all the wisdom and all the knowledge to be able to come up with a syndromic interpretation. With the history, biomechanism of injury, translate that to the trauma impact, translate that to possible injury, and from that, you do intervention. I know that at your level, you may not be able to do it, but that's why in a system where you activate the specialist in time, and we have done it so many in this hospital. Open thoracotomy, you see, degloving of the face. So many things we have done. So, but anyway, sometimes it irritates the surgeon, irritates the orthopedic surgeon. They say, oh, it's our territory. But very simple, we tell them that if you come later than we need you, you become irrelevant. Now, irrelevant means that we don't wait for you. We do it when it's needed. Now, back to what you see just now, I am sure if you have a good collaboration with the orthopedic surgeon and so on, when they send MO to come to the department to manage because they are busy, between the MO and our PACA, who is better, you think? That's why not that we don't trust them, but in an understanding whereby if you are not around, let us do it for you. That's where we can have a relationship. Well, I went through a lot of issues in this department where we try to do intervention. Because we want to do early intervention, basically because we know the patient needs it at the time. We want to do damage control resuscitation, but sometimes they don't like it because, oh, why don't you wait for us? The classic one, for example. Many situations you have fracture dislocation. Fracture dislocation of the ankle, for example. We cannot immobilize the patient in a deformed position. Supracondylar fracture and all this. We cannot wait for them because we know that the blood supply will be affected. So we give trauma, we give auxiliary block, or we give bias block, then we reduce. And they say, hey, why you do all these things? We say, sorry, because we want to damage control. So that concept of damage control is important, where we therefore must have the ability to intervene in good time. Now, for the sake of preventing further negative impact, we therefore must know. Now, that's why I was quite happy to see what has been done in Sungai Buloh, and now we are now doing it in Hospital Kuala Lumpur to identify what needs to be done as soon as possible. But bear in mind, I'm talking now about trauma, but damage control resuscitation is also being applied in medical field. Example, thrombolytic therapy. We have managed a very interesting good friend of mine who came here from Putrajaya, who have got a stroke. The head of the dental faculty of UKM, my very good friend, my senior in school. We brought from Putrajaya, the son called me and said, my father collapsed at the lobby. I said, don't stop anywhere, bring the patient here. You know what we did? We did stroke management, huh? We did thrombolytic. And he survived now. He applied with him about a few weeks ago. And these are the things that actually is enough justification for us to acquire the capability and the competency to do so. That's why I applaud all these attempts to improve your skill. Remember what I said about competency-based education and competency-based practice. It's not enough for us to chase for diagnosis. Because we chase for diagnosis, it will take time. I used to tell them what we call consequentialism. Consequentialism means look at the patient, work the diagnosis, possible diagnosis, not exact diagnosis. 100% clinical phase, we should do something already. Simple thing like immobilization or analgesia and so on. Okay, and then we investigate bedside, then we improve our intervention. Finally, we do consent patient for definitive investigation, then we can do definitive care. This phase is important because if you wait for diagnosis, but 1 or 2 hours later, like I said to you, the metabolic response to injury will kill the patient. You will know the theory behind it already. I didn't have much time to go into the specific. All you need to remember, metabolic response to injury, the amplification of it cause problem. What example? Give example. One example. One example of negative impact of metabolic response. Just one. Adrenaline cause insulin resistance. Okay? Got it? If you remember that, I think, okay, I remember something. Okay? The second one, overfluid resuscitation. That's also, you tend to put in a lot of fluid. All right? In metabolic response to injury, what happens? What is the word for it? Just now you talk about insulin resistance. Okay, you? Tak berhasil lecture saya, nah. Capillary permeability. Okay. Capillary permeability. Because of the fact that then many more fluid and many more what we call particle can go up to the spaces that can go there. Okay. What is the important effect of crush? What are the negative effect of crush syndrome? What are the things that you worry about? Crush syndrome. What did I say? Sorry?
Release of the inflammatory muscle after release of the pressure, so it can cause like injuries to multiple systems, such as release of mind body.
Because of okay. Good. Now, what is the effect of free fatty acid? What is the indication if we have free fatty acid? What does it mean? Free fatty acid is produced by lipolysis. Lipolysis happens when there is not enough insulin that can absorb, because we have to release energy from the fat. And when you release free fatty acid, it causes insulin resistance and it worsens the situation. Got it? So therefore, now what do you understand by permissive hypertension? Because these are keywords, you know, in damage control. It's okay. You don't know this. Okay, I understand. Me too. When I listen to lecture, I chapati, lapar kukari, and all this kind of thing. To reduce the pressure in the blood vessels. Okay, what do you mean by permissive hypertension? Permissive means you allow. Hypertension means bring the blood lower. Okay, but why? Capillary permeability causes fluid to go into the third space. We don't want that to happen. Who's the guy who talked about cadet method is from Houston. If somebody asks you, what do you mean by computation? We try to keep the patient dry to prevent the space with transfer, and only can be done in facility that can have the palliative care within the area. I want to say all this. These are the take-home point, okay? Then you all go back and say, hey, I learned about DCR. And DCR means we do intervention as soon as possible. So DCR, classic. What you saw, what the is DCR. Damage control circuit is also got a suite there. Translated the philosophy into reality. Now, with that suite availability, high-level intervention can be done. So somebody said, somebody asked you, what do you mean by DCR? DCR means I bring high-level intervention as soon as possible. Okay, without much. So, one more. If somebody said, okay, hemorrhage control. Hemorrhage control. What are the methods you learn from my lecture? Sorry? You cannot say like that. Compression, you can say something more specific. Compression, okay, boleh, tetapi not just compression. This is more specific. One, simple one. To negate. Then, hemostatic power. That. Ligation. Just remember all this word, because what you want to do is to be able to take home some information. You listen to my lecture, look at your lecture. But I know that too. I was studying before. Was a very large, I was higher compared to Bulan. Okay, so my lecture combined with his drama there, you should get from a lot of things. No? The reason is because all that drama actually justify what I'm doing. Okay, so why do we do damage control resuscitation one more time? Kenapa kalau berani jawab? Kenapa you buat damage control resuscitation? To prevent? Apa dia punya filosofi? To prevent our body ada metabolism response. Betul? Kalau metabolism response ini terlampau besar dan terlalu apa akan jadi? Ia menyebabkan nanti kita punya organ akan rosak disebabkan oleh massive vascular constriction because of the adrenaline dan sebagainya. I want you to take on something. Janganlah itu angguk-angguk saja. Jangan malu. If you don't know, you ask. Because why? I want to have a before and after. Before you beban, after jangan beban. Tapi kalau masih beban macam ni, saya yang berdosa tetap. Because I didn't make my lecture good enough. That's why I'm doing this summary. Because I want to make my lecture good enough that I impact pada kamu. Boleh? Okay. Who can tell me what is the basis of crash syndrome management? What's the basis of crash syndrome management? What did we say? There is that ayat, there is a quotation that he says and I say, yeah? Again? Apa itu? Solution is a solution to pollution. Why? Because when you release the pressure, there will be a lot of product of anaerobic metabolism. Example, glycolysis microbial, lactic acid, acidic material. Oh, so many. So we dilute first. Alright. So we flushing fluid ready. Kalau release saja dia tidak. So give a classic example of this that I say happened in Chengdu. Yang belakang sana. What is the word for it? Crash syndrome. There is a death in Chengdu. What is that called? Smiling death. Smiling death means that patient is okay when doing the operation everything. Few hours later, your blood will pick up because of those things. Nephrotoxic, myocardial impact of the metabolic toxicity. So what I have done just now is to tell you all about this, and this I would like to motivate you to acquire skill for that purpose. To make sure that you all know, hey, I want to be able to intervene in good time. You go to the site, this patient and track in your mind, there may be possibility of crash syndrome. So don't put blood yet, put fluid dulu. And then bawa to hospital if you want to convert it to commercial hypertension, you can do. Tapi in the beginning to prevent the negative impact. Okay, so I think I've used a lot of the time. I'm supposed to speak half an hour, but I will never be able to do it. So never mind. He took my time, so I took a bit of your time. So thank you very much. Any question anyway? Any question? Nobody dare to ask me question anyway. Okay, thank you very much.
Thank you very much. Now, let's watch a video. Now we have come to the end of our trauma week. So now I would like to invite Datuk Dr. Mahada. So I'd like to invite Professor Retusti Abasan to receive doctoral certificate from us. Ya, ada lagi. Ada kita juga ada award untuk best participant, maksudnya yang datang setiap hari dan juga terlibat secara aktif, very proaktif. Jadi untuk ni kita sebulan suara telah memilih PPP Faiz.
Sudah buku poster.
Juga ada untuk best facilitator, kita telah memilih Dr. Nabila.
Dia pegang yang ini.
Pertamanya, terima kasih Dr. Ibrahim dan rakan-rakan yang mengusahakan the trauma week punya session. Yang daripada bahagian Dr. Puasan, mentor saya masih lagi mentor ini Dr. Syah dan rakan-rakan pakar-pakar yang lain dari jabatan. Pertamanya saya banyak terima kasihlah kepada urusan yang mengkoordinasikan trauma week. I think the response I think overwhelming. Daripada hari pertama sampai tak cukup ruang dalam dewan ni, cuba curi-curi masuk dan sebagainya dan menyusahkan orang lain. SOP memang terlaut terus. Jadi overall response utamanya yang melibatkan the procedural punya komponen. Kita amat faham situasi, mengapa situasi ini berlaku sebab
kita has been lagging behind in terms of the training over the last few months, so on and so forth. And more so, actually, there are many of you actually new in this particular department. And then commonly, actually, the management of trauma is always the weakest link, ataupun the gap that we need to address quite fast actually when you attend this department. So, but this is not something that we're going to do one-off, and this continuous training has to be continued, to be monitored, so that we can have a proper, what we call, outcome from this particular sort of training. And secondly, we also, I think in this institution, we already have devised several what we call training program, which is modular in methods, to cater for such needs. So for all the categories, and I'm sure this also has been advocated in other institutions as well, facing these issues of training that we have in our ministry dan sebagainya. Jadi I do hope, I am sure that we all benefited from this particular session. But importantly, actually, from now and then, kita kena enhance and emphasize actually the competency and the knowledge that we have. So, but after 2 weeks, you're listening to these lectures. Kalau kita tak guna, kita tak praktikan dengan sebaik mungkin, dia akan result out as if that you do not attend this particular event. I think once again, thank you very much for all the facilitators that are working hard to ensure that this event is a success. With that, I say thank you very much again, Dr. Tahib, for allowing me to actually speak a few words. Sebenarnya saya tak hadir secara fizikal, tetapi saya daripada pagi tadi saya dengar lecture Dr. Lee. Dan ada masanya saya meeting, ada beberapa kali sebab ada satu masa lah. This is the adverse effect of having this virtual platform. Kita boleh buat 3-4 meeting dalam satu masa. But actually I'm there. I'm also been listen juga Prof. Dr. Singh lecture tadi, tapi the first 10 minutes saja. Sebab lepas tu semua dia macam dijaga boleh. Benda yang sama ulang-ulang kali. Saya rasa over the last 20 years pun. Saya berapa dah satu previous speech on this aspect. Okay, with that, thank you very much. I pass back to you. Thank you very much again.
We have come to the end of our trauma week. So I wish to congratulate and thank those who are involved, especially the facilitators, and also to all the participants who were very proactive. We hope that you benefited from this trauma week. This is not the first and last, but we will continue to do this periodically, at least minimum 6 months. Alright, terima kasih semua. Kita jumpa lagi dalam next trauma week.
Oh ya.
Kamu No, but maybe you can reverse it.
Yo, tu kamera yang paling mahal. Ada 3 mata. Semua ada 3 mata. Itu ada. Macam boleh forward sekali.
Oh, okay.
Kena trauma.
Alright, thank you.
I was a E on big batch. I only tried. This one big batch. This one. Yang main bola pun. Dua.
Oh, the history lah.
Dua salah batch.
I was bench HKL.